Hi friends, this is Dr. Apoorn Mehra and welcome to this quick revision of orthopedics in English. Now, this is the only time where you will listen to me speaking calm, but before we start, let's talk and speak to our parents as a word and note of thanks for making us doctors. Let's start by remembering them first. Subsequent to that, let's thank good God above for blessing us with this wonderful branch of being a doctor. And I thank Almighty for being a teacher. Thank you very much. So now let's start with the father of orthopedics. Now the father of orthopedics is the name that you guys need to remember is Nicholas Andre. Nicholas Andre gave the branch, gave the name, gave the emblem, wrote the first book. Now Nicholas Andre coined orthopedics, which means straight child. So you have two questions coming from here. What does orthopedics mean and who is the father of orthopedics? Now, Britishers felt that they own everything. So they came with a new term which is called as the British father, Sir H.O. Thomas. So Thomas is the second best answer if Nicholas Andre is not given. But if Nicholas Andre is given, he is the best father. So we have a paternity issue. We have two fathers. Now, Thomas had a nephew, Sir Robert Jones, who is called as the father of modern orthopedics. And today is the world where joint replacement is number one done surgery in orthopedics. And which joint? The largest joint in human body, the knee. So the pioneer of knee replacement, John Chanley, is called as the father of arthroplasty. Now, if you want to summarize out of these fathers, there are 2 points which always comes in MCQs. Number one, who gave the splint? This is called as a Thomas splint, and it was made for tuberculosis of knee joint. This is what Thomas made it for, TB of the knee joint. And the second one is a Thomas test, which is for hip flexion deformities. Hip flexion deformities. So these are two things which were done by Thomas, which is asked to you as very important questions. So there are a lot of questions on this page, but if I need to take away one, remember that Thomas test for hip flexion deformity is the number one point that I will take away from this page. When I look at orthopedics as a branch, right, X-rays are usually the number one investigation that you do. And X-rays can show you a bone. So here is an image which shows you a contrast between an X-ray and a bone. And what you need to understand here is X-ray can show you everything on the bone and also the layers of the soft tissue outside. But what it can't show you is the cartilage. So the cartilage here is not picked up on X-ray. So it will show as empty space. So if you look at the bone on the top has a cartilage covering, and cartilage is got type 2 collagen, cartilage. So cartilage. So it has type 2 collagen, and our bone has got type 1 collagen. So it has got type 1 collagen. All right. So the parts of the bone subsequently are the epiphysis. The epiphysis is something that will have chondroblastoma or a giant cell tumor, in this order ECG into it. Epiphysis, right? If you choose chondroblastoma is number one thing that you will choose before giant cell tumor. If you look at the metaphysis, you have two things here, infections and tumors. And which tumor is number one here? Osteosarcoma. And coming to diaphysis, you have three vowels here, that is osteoid, osteoma, O, adamantinoma, and Ewing's sarcoma. So these are the important things which are in the different areas of the bone. So what I want to tell you here is X-rays are the first investigation which can show you the bone, can show you the soft tissue layers, right? But cannot show you the cartilage, all right? When we talk about bone, right, the bone principally is made of two parts. The inorganic part, which again is your MCQ, which has got calcium hydroxyapatite, Ca10, PO4, OH2 minus. This is the formula for the same. And the organic part, which has got type 1 collagen, giving the tensile strength to the bone. And imagine this type 1 collagen, if it is defective, the bone will have multiple fractures. And what disease are we talking about? We are talking about a condition called as osteogenesis imperfecta, type 1 collagen defect. All right. As we grow, the epiphysis fuses with the metaphysis and the physis of the growth plate disappears. This is called as skeletal maturity. So remember, this is the milking position of human beings. So the three joints which are facing towards God above, they grow more, right? So they grow till the 18 years of age. And the three joints which look down to the ground, they fuse early, that is 16 years. So what age does the longitudinal growth of the joints stop? So 18 is shoulder, 16 is elbow, wrist is 18. So alternate 18, 16, 18. And if knee joint is 18, so hip and ankle is 16, 16, 18, 16. So this is how you remember when you become mature, you take the responsibility of the family on your shoulders and you stand on your knees. So these two joints ossify at the age of 18, the ossification centers fuse and the longitudinal growth ceases. So this is something which is very, very important to know about skeletal maturity. Coming to epiphysis now. Now, epiphysis is an area which is at the end of a bone. So, the end of a bone, for example, the head of femur or the head of humerus, these epiphyses are the pressure epiphyses. They are taking the weight on it, right? And these are the first ones to ossify. So, the pressure epiphyses are the ones which are covered by type 2 cartilage. All right, then around the joint, there is pull of a strong muscle, like around the trochanters, you will have gluteus medius and minimus. Around the tuberosities, you will have rotator cuff muscles. These are called as the traction epiphyses. And remember, rotator cuff muscles is an MCQ that comes to you, remembered by mnemonic SITS. Remember the way I have written it. Supraspinatus, infraspinatus, small I, small t, teres minor. All three goes on a greater tuberosity of the humerus, and on greater tuberosity of the humerus, they will do abduction, external rotation. And then the dash subscapularis, which is an internal rotator, goes on lesser tuberosity. So when you rotate and take your hand back, this is subscapularis, and when you further rotate, this is a lift-off test by subscapularis. So this lift-off test by subscapularis is important for all of you to remember. And remember, this subscapularis is also called as the forgotten tendon of rotator cuff. Subscapularis. All right, it's called as a forgotten tendon of rotator cuff. This is something we should remember. Then you have got aberrant epiphyses. These are not of much significance, like the head of the first metatarsal. So these are something which you should know. And then you have atavistic epiphyses. Atavistic is something which is in animals, maybe not so significant, but in human beings, they come and attach to the parent bone, like the coracoid process of the scapula, which is a very important landmark for the shoulder surgeries. So this is atavistic. But if I have to remember one, traction epiphyses around the femur, the gluteus medius and minimus, the main abductors going on the greater trochanter. Around the shoulder, the rotator cuff muscle, the sits going on the greater and the lesser tuberosity, and subscapularis, the forgotten tendon, which is the question here most commonly asked, and the rotator cuff muscle name is the second question here. Now, when I look at the physeal injuries in the children, right, we have got Salter-Harris classification. Now, Salter-Harris classification is for epiphyseal or physeal injuries in children. And this is what it means. If the epiphysis slips from its position, right, and there is a break in the physeal zone, in the growth plate, this is called as type 1 injury. So you can write a 1 here. And when it goes to the physis, which zone of the physis? It goes to the zone of hypertrophy of the physis. All right, zone of hypertrophy of the physis. And then comes the epiphysis with the metaphyseal part. Salter-Harris type 2. This is the commonest one, called as Thurston-Holland sign. Thurston-Holland sign. And then type 3, where the epiphysis breaks into two parts. Then we have type 4, where the epiphysis breaks with a metaphyseal chunk. And then comes type 5, where there is a damage to the physis. Type 5 is physis. So these are type 5s, 1, 2, 3, 4, 5, which are very, very important Salter-Harris classification. Commonest is type 2, the Thurston-Holland sign. And which zone of the physis do they break through? Zone of hypertrophy. Coming to the next thing now is about the x-rays. You know, when I look at the x-rays, I told you that the x-ray can show you everything except the cartilage. This is very important. So this is the last point here. The joint space which you see is cartilage because the cartilage is radiolucent. Now, x-rays can show you the bone. In the bone, when you look in the bone, there is a cortex. So break in the cortex is called as a fracture. Fracture is not break in the bone. Fracture is break in the cortex. Number 1 point. Second point, in orthopedics, everything starts in the marrow. So diseases, they start in the marrow. So it can show you the thick outer layer of cortex in the inner spongy bone called as the marrow. This is what the x-rays can show you, and the break in the cortex is called as a fracture. Then the second thing which x-rays can show you, the soft tissue plane like the muscles, the deep fascia, the fat, the superficial fascia, and the skin. Right? So it can show you the layers. It can't show you the muscle, but it can show you the muscular layer, the fatty layer, and the deep fascia. Now, this is something very, very important because as you have bone infections called as osteomyelitis, osteo means bone, myelitis means the infection going in the marrow and causing the inflammation. In osteomyelitis, in first 24 hours, the x-rays do not show anything. They're quiet. But after 24 hours, as the inflammation keeps on going, the muscle and fat layer merges into each other. So these beautiful layers which are shown here, they are gone, called as loss of soft tissue plane, which is earlier than a periosteal reaction. The periosteal reaction comes at day 7 to day 10. We will see what is the periosteal reaction. It is a sheath on the bone. It's a different thing. All right. So that's not the first change you see on bone in osteomyelitis. The first thing seen on the x-rays is loss of soft tissue plane. Similarly, our spine has curvature. Our cervical spine goes in, called as cervical lordosis. The thoracic spine comes out, called as thoracic kyphosis. Lumbar spine goes in, called as lumbar lordosis. So we have got curvature. So if there is an infection of the spine, like tuberculosis, the muscle spasm will come, and these curvatures which are there will be lost, called as loss of curvature of spine, which is the earliest feature on the radiology for a tuberculosis. Quite earlier as compared to the reduced disc space. We will see that in the section of tuberculosis. When and why will you see a reduced disc space? So that occurs later. So again a point. And the last point which I told you, the joint space here is made by the cartilage. All right, and cartilage is not seen on the x-rays. So which joint are you seeing here? Knee joint. Knee is the largest joint here. What all can you see here? You can see a tibia. You can see a fibula. What goes here? The common peroneal nerve. And common peroneal nerve palsy, what does it causes? The foot drop. They ask you a question that a patient has got high stepping gait, means to take away his foot drop, he has to step high. Right? Which nerve is damaged? Common peroneal nerve. Where? Neck of fibula. Or they will show you a foot drop and ask you, where is the nerve damage? Neck of fibula. So common peroneal nerve. And what is this, my friends? This is patella. In fact, in one of the questions now, they had only shown the AP view and asked you with a fracture there, what is it? So there was a fracture of patella, and this is a femur. All right, the largest joint, there's a joint space. Right, after age-related damage, joint space can be reduced. This is called as arthritis. So what is arthritis? Destruction of cartilage, causing reduction in the joint space, causing deformities. What are deformities? Deviation from the normal. So if I look at my elbow, which is called as a cubitus, and if I look at my forearm and hand, if it goes towards the midline, it is called as cubitus varus, going towards the midline. If the distal part goes away, it's called as valgus, because in valgus there is a L. It means the distal part goes laterally. All right, so this is cubitus varus, cubitus valgus. So if I look at the osteoarthritis of knee, it is called as OA. It will make a O in between the legs called as genu varum. It's more commonly seen. And in cases of rheumatoid arthritis, you will see valgus. So it's like a R in between the legs called as RA, rheumatoid arthritis, valgus. So these are the deformities O and R that you should remember. There are some certain points on the x-rays which are very important in the upper limb. For example, if I look at shoulder, remember the highest point on a shoulder is clavicle, and just beneath the clavicle you have the coracoid. So coracoid, sometimes they mark and they ask you what is this? So coracoid, right? Very important landmark. At the elbow, you have capitulum. Sometimes they just mark in the exam, what is this? Capitulum. And why do they do that? Because at the elbow, capitulum is the first center to ossify at the age of 2 years, radial head at the age of 4 years, internal or medial epicondyle at the age of 6 years, trochlea at the age of 8 years, olecranon at the age of 10 years, and external epicondyle at the age of 12 years. Sometimes they also show you a fracture of radial head and ask you what is it. That is at the age of 4 years it appears, and this is something which is fractured. So this is the ossification around the elbow. Similarly, at the wrist joint, they can mark a scaphoid and ask you what is it. A boat-shaped bone. S for scaphoid, ossified at the age of 5 years. Or they can mark the capitate, the largest carpal bone and also the first to ossify. And then they can also mark the lunate, which appears like a moon, more on the lateral view, because scaphoid and lunate, their relationship is very important. Also remember one thing in the lateral view, the first metacarpal of the thumb. The first metacarpal of the thumb on the lateral view is anterior or volar. That will help you to diagnose different fractures when we come to trauma. So this is extremely important. And the mnemonic for remembering the carpal bones is very simple. She looks too pretty. Try to catch her. S looks like 5. You go in the descending order, 4 years, 3 years, total them out, 12 years. So 5, 4, 3, 12, right? Now the total of the second row is 12. Try to catch whom? The she. So that also becomes 5, 5, 1, 1, and the first to ossify is capitate. So total of 5, 5, 1, 1 is 12. So she looks too pretty, try to catch her. Age of ossification, that's scaphoid, lunate, triquetral, P for pisiform, trapezium, trapezoid, capitate, hamate. So these are the 8 carpal bones and their ossification. So this is about the upper limb x-rays. Coming to some certain x-rays which are very important. Remember one dictum. A young female with bilateral hand pain with morning stiffness is rheumatoid arthritis. Young female, bilateral hand pain with morning stiffness is RA, right? Similarly, young man with low back ache, with sacroiliitis, with reduced chest expansion, with decreased lumbar movements, with redness of the eye, with heel pain. All these are key points for ankylosing spondylitis. And the most important thing in ankylosing spondylitis is sacroiliitis. Remember, my friends, RA, the most important joint is metacarpophalangeal, MCP. And to diagnose ankylosing spondylitis, which is associated with HLA-B27, the most important point is sacroiliitis. Coming to the x-rays of the pelvis, one more x-ray. The upper end of femur, along with the pelvis, makes an arch called as a Shenton's arch. If there is a fracture of the pubic rami, dislocation of the joint, or of the upper end of the femur, this arch is gone, called as broken Shenton's arch. Remember, the CT scan can show you 2 things which starts with just like C for CT scan, C for cortex, C for calcification. But our subject, the king, is MRI. MRI can show you the marrow, most of the bones, MRI can show you the soft tissues, and MRI can show you the cartilage. Cartilage, my friends, is not seen on X-ray, is not picked up on CT scan, is picked up on MRI. For example, in your exam, they just love to show you the sagittal view of the knee joint. So knee joint sagittal view, what will that show you? It will show you a beautiful tibia. It will show you a beautiful femur. And remember, from the posterior aspect of femur, two things come out. One which goes anterior, called as the anterior cruciate ligament, ACL, and one that goes and attaches most posterior on the tibia, posterior cruciate ligament, which permits external rotation of the leg, and anterior cruciate ligament, which prevents tibia going anterior to the femur, called as hyperextension, and the internal rotation. So this is what are the movements which it restricts, and if they are broken, these movements will occur excess. You know, if I do a long running, after some time I might hurt my legs and my feet. Now, why will this happen? Because I am giving excess force to a normal bone. These are called as a stress injury, and these cases the X-rays can't pick up the fractures. X-rays pick up the cortical breaches, but in this area the marrow swells up. And what picks up the marrow? The MRI. That is why for marrow edema, right, is seen in stress fractures or occult fracture much earlier than X-ray will show you. And that is why for stress fracture, the IOC, the investigation of choice, is MRI. In my subject, X-ray is usually the first investigation, but MRI picks up almost everything. So next investigation is going to be MRI. Now, if I do long running, my entire body will be under stress. And that's why there's an investigation called as bone scan, which picks up the osteoblast. If there is a damage to the bone, the osteoblast will repair. The bone scan will be positive. All right. If there's an infection to the bone, osteoblast will repair, bone scan will be positive. If there's a metastasis like prostate, which has got osteoblastic activity, the bone scan will be positive. So bone scan picks up the osteoblastic activity. So B for bone scan, B for blastic activity, B for bilateral stress fracture. So when you look at stress fractures, overall is MRI, unilateral is again MRI, for bilateral is bone scan. And there are some names like March fracture, the commonest one is metatarsal neck, second more than third. Upper limb is olecranon. In spine, there's an area called as pars interarticularis. We will talk about it. All right. And the treatment is cast or rest. There is another name for this called as the shin splints. This also means the same, a type of a stress injury, and MRI is the investigation of choice. I just spoke about prostate metastasis is osteoblastic, can be picked up on bone scan, but for metastasis, you need to pick up the tumor cells, right? And what can pick up the tumor cell? An investigation called the PET scan. In PET scan, you give deoxyglucose to the patient, which is radioactive fluorine labeled. Now, anaerobic metabolism is a feature of the tumor cells. So they will be picked up deoxyglucose by the tumor cells and will show radioactivity like the yellow spot here. That is why when you have metastasis, single metastasis, MRI is the investigation of choice. For multiple metastasis, PET scan is better. But when you have multiple osteoblastic mets, like in prostate, bone scan is better because in osteoblastic mets, PET scan is quiet. So overall, what I understand here is in orthopedics, the next investigation is usually MRI. But the best or the gold standard, what is the best or the gold standard for infections? Grow the organism on culture media. How will you get the sample? Take a biopsy. What is the best investigation for a tumor? See the tumor cell under a microscope. How will you get the sample? Go and do a biopsy. So remember that tissue is diagnostic, radiology is suggestive. So I'll just give you an example, right? Pain, fever, and swelling. What comes to your mind first? Infections, right? Correct? But one thing you should keep in mind also in orthopedics, that pain, fever, and swelling is also clinical presentation for two highly aggressive tumors, that is Ewing's and osteosarcoma. Although infections are in the metaphysis and osteosarcoma is in the metaphysis, Ewing's is diaphysis. All right. Second point is, if you want to differentiate infections and tumor, you take a tissue, divide it into two parts. One part goes for histopath, tumor will be seen if it is there. One part goes for the culture, infection organism will grow if it is there. Which is the most important organism in orthopedics, my friends? We'll do it in the next part. But yes, for you to remember, Staphylococcus aureus is the king of orthopedics. And in investigations, the king is the biopsy or the tissue diagnosis, which is important. DDH, that is developmental dysplasia of a hip. The problem is normally our head is encased in a deep, wonderful acetabulum. But if the acetabulum is shallow, our head will migrate into different areas. This is called as congenital dislocation of hip or developmental dysplasia of hip, and its investigation of choice is MRI. But if you want to screen thousands and thousands of students, the screening tool is ultrasonography. Now, if I look at the bones, bones are mainly cortical part or the medullary part or the marrow part. But when I look at the joints, I'm looking at the cartilage. So looking at the cartilage, the order of investigation, number 1 will be X-ray, number 2 will be MRI, and number 3, there's fluid inside. So that fluid you can aspirate and send for investigations. Or if it's a trauma, you can do an arthroscopy. An arthroscopy most commonly is done knee followed by shoulder in this world. All right. So remember this mnemonic: X-mass, X-ray, MRI, aspiration oblique arthroscopy is the one that is done for the joints. And remember one more thing, the aspiration is always done preferably ultrasound guided. Now coming to the periosteal reactions, what is a periosteal reaction? It is a shout of the bone to the world, I am getting destroyed. If the periosteal reaction is single, just a single layer outside the bone, it is called as a solid periosteal reaction. And solid periosteal reaction indicates benign tumors or osteomyelitis. And on osteomyelitis, day 7 to day 10. But then this is called as a narrow zone. And this is called as a solid periosteal reaction. But as compared to it, aggressive or wide activity is seen in chronic infections or malignant tumors. For example, you can have multiple rays coming out. It can be seen in any malignant lesion, but usually osteosarcoma. It can also be seen in chronic osteomyelitis. Or a layer of the bone comes out, the periosteum comes out with a bone formed underneath this periosteal layer, called as a Codman's triangle. Can be seen in any malignant bone tumor or chronic infection, but usually again osteosarcoma. Or there can be multiple layers over the bone, can be seen in any malignant lesion, but usually heaving sarcoma. So this is something you should remember. These are wide zones indicative of more chronic or aggressive diseases. So here is a table: sunray appearance or Codman's triangle, osteosarcoma, but can be seen in any malignant lesion. Onion peel appearance, Ewing sarcoma, but can be seen in malignant lesion or chronic infections. Soap bubble appearance, the bone is getting expanded and destroyed, classical for giant cell tumor or adamantinoma. Giant cell tumor is an epiphyseal tumor, adamantinoma is a diaphyseal tumor. Calcification, what does the calcification means? It means the cartilaginous tumors. Different patterns of calcification, cartilaginous tumors. Patchy calcification, chondrosarcoma more than chondroblastoma. So malignant cartilage more than benign. And uniform calcification, that is homogeneous calcification, seen in osteogenic tumors like osteosarcoma. Like, this is what I mean to say: cartilaginous tumors will have different patterns, osteogenic tumors will have uniform calcifications. And this is a classical image, number 1 asked image in orthopedics. Here, look carefully. This is the joint, and the joint goes till the joint. So joint goes till the joint. This is giant cell tumor. Tumors, right, they respect the cartilage, they respect the joint. Infections, they eat the cartilage, they eat up the joint. The only tumor which can go till the joint is the giant cell tumor. And if you have a tumor of the lower end of radius, you will mark giant cell tumor TPO, till proved otherwise. This is something you should always remember. So what I learn here is biopsy is the gold standard for tumor infection. Multiple METs, PET scan is better than bone scan. Bone scan is better for osteoblastic mets like prostate. In osteomyelitis, X-ray is first, then MRI, but MRI will show you changes earlier of the marrow edema. This is what you should remember. Infections. One organism that should come to your mind very clearly is Staphylococcus aureus. And remember, infections in the bone, they come through the blood and they are metaphyseal. You know, ortho is married to staph, staph is married to ortho. This is something that should come to your mind when you're awake, sleeping, living, or whatever. But Staphylococcus aureus is the number one organism to be marked in ortho. Get it straight. If you remember this, you remember infections. All right. And you know, the second organism that you come according to you on the MCQs, right, is the sickle cell anemia having salmonella. But remember, it's in the diaphysis. Drug abusers or foot wounds, right? Think about Pseudomonas. Open injuries, our staff is back again. The most dangerous bites in the world are the human bites with Eikenella, and the animal bites is Pasturella. But the key word is Staph aureus. Second is sickle cell anemia, salmonella. Coming to when you want to diagnose osteomyelitis, the movements are absent in that limb. That's a key point. So reduced movement of the limb, right? Toxic child, not eating and not sleeping is toxic. High fever, high erythrocyte sedimentation rate, that is ESR, high CRP, that is C-reactive protein. These are indicators of a toxicity of infection in the body. Osteomyelitis in the first 24 hours, the X-rays are normal because it takes 24 hours to show the soft tissue plane is lost. But MRI can pick up in 10 to 12 hours, and 12 to 24 hours is the bone scan that can pick up, right? And when you have infections in the bone, even before the soft tissue planes are lost, they can be managed non-operatively with an antibiotic, which is initially given IV and then started oral. Monitoring is done with ESR and CRP and the clinical sign. And remember, the antibiotic should cover which organism? Staph aureus. Brilliant. And when in osteomyelitis more than 24 hours, there is a loss of soft tissue plane. It means the infection is trying to come out. MRI is positive anyways. Bone scan already positive in first 24 hours. And right treatment is operative. So whether you operate or you don't operate, the antibiotic duration is the same, 6 weeks, that you should remember. Coming to joint infections, which are very, very aggressively treated because within 3 hours, the infection or staph can eat away the cartilage, the type 2 collagen. So you need to understand if there is loss of joint movement and you have a suspicion, open it. That's called as arthrotomy. And if the child is 5 years or less, toxic, absent movement, septic arthritis is a name. Septic joint is a better name. Arthritis means damage to cartilage. Actually, the cartilage will get damaged if you don't treat it properly, but this name has been used since times immemorial. So this is a misnomer. Septic arthritis. Staph aureus is the organism anyways. X-ray, MRI, aspiration. Aspiration by ultrasound guidance. Send it for culture sensitivity and for fluid analysis. And then treatment is arthrotomy, opening the capsule with antibiotic for 6 weeks. Remember one thing, knee is the commonest joint affected in septic arthritis. Lower end femur is the commonest area affected in acute osteomyelitis. So the knee infection will come from the bone. That's why the duration of antibiotic is 6 weeks. But the difference is in osteomyelitis, first 24 hours non-operative management exists. But in sepsis of the joint, it is going to be very aggressively managed, operated. Similar mimicking condition, that is age group 6 to 12 years, all right, with non-toxic child, decreased movement. This is called as temporary transient proliferation of the synovitis. Order of investigations again XMAS. Treatment is rest because it's temporary. It will go back. Transient synovitis. Now here is something written. Faber at the hip joint. What is Faber? Faber means flexion, abduction, externation. Flexion, abduction, externation. This means increased capacity of the joint. It also means there is lengthening. The limb will lengthen. This is seen in 4 conditions. Infections. We just saw Faber. Right? Synovitis, that is transient synovitis. Iliotibial band contracture, that goes from ilium, crosses the hip, crosses the femur, crosses the knee and goes on tibia. If it contracts in polio or cerebral palsy, that is the iliotibial band contracture will lead to Faber and the anterior dislocation. So these are 4 conditions where you have Faber. Anterior dislocation of hip is the last cause. Why? Because it's very rare. So which dislocation is common? Posterior. That is why opposite of it, flexion, adduction, interrotation, Fader is more commonly associated with posterior dislocation or arthritis. The difference here is arthritis, the cartilage is destroyed, just not like septic arthritis where pus presence means septic arthritis. So means if you have septic arthritis initially, there will be Faber and it destroys the cartilage. Will it become Fader? True. If there is tubercular infection of the hip joint, initially there is synovitis, there will be Faber. As it progresses, will it turn to Fader? True, because that will cause arthritis or damage to the cartilage. And this is what is written, posterior dislocation of the hip is more common than anterior dislocation. Also remember, Fader will always have shortening because abduction abduction will have lengthening, and adduction will have shortening of the limb. This is what you should remember. Going to next, Tom Smith arthritis. What is Tom Smith arthritis? A child with epiphyseal destruction because of infection. The femur epiphyseal destruction is Tom Smith arthritis. And what does it have? It has hypermobile joint because it has got hypermobile joint that is destroyed. So initially when the infection is there, absent movement. But as it gets destroyed because the head has gone, so it is called as septic arthritis of hip joint in infancy. Septic arthritis of hip joint in infancy. What is eaten up? Femur capital means head, epiphysis. All right. Then after acute osteomyelitis, what comes? Something that is called as subacute osteomyelitis. Some books also call this as a chronic osteomyelitis. It's a named thing. It's a named thing. Lytic cavity with sclerotic margin, usually in the tibia upper end or maybe in the lower end. Remember, it is seen only in immunocompetent host. Immunocompetent host. What does that mean? It is not seen in HIV positive. It is not seen in HIV positive. Remember that. And then as the infection progresses and there's a dead bone, that's called as sequestrum. The bone shape is altered. There is a cavity in which an isolated piece of bone is there called as sequestrum, which is diagnostic. Sequestrum means isolated, surrounded by a live bone called as involucrum. Now, this sequestrum is a sign of infection and you need to take it away. When you remove the dead bone, right, the bleeding bone comes up. That's called as a paprika sign. Remember, whatever is alive will bleed and will hurt. So, if I look at this image here, in the center of the bone, there is an isolated bone called as sequestrum. Surrounding it is called as involucrum, the live bone. And then we have the draining sinuses coming, right, on the surface of the bone called as the cloacae, which is diagnostic feature, the sequestrum, right? And when you take away the sequestrum, that's called as a paprika sign. And the instruments used to do that is, this is bone nibbler or a bone cutter, which is very commonly used in the surgeries. What is paprika sign? Removal of sequestrum, bleeding, good bone. Also remember, when you treat chronic osteomyelitis, your principle of treatment is remove the sequestrum, control the infection, fill the gap, because if you leave a cavity in a bone, it will break. And finally, provide a good soft tissue coverage. How do you provide good soft tissue coverage? By vacuum assisted closure or negative pressure wound therapy. NPWT, negative pressure wound therapy, where the pressure is minus 75 to minus 125 millimeters of mercury. So it's negative pressures in the wound therapy, which is very, very important. And remember, multifocal osteomyelitis, what does it indicate? There's a syndrome called as SAPHO syndrome, which means synovitis, acne, pustulosis, synovitis, acne, pustulosis, hyperostosis, osteitis. Now, this is SAPHO syndrome. It means it's actually not an osteomyelitis. It's an autoimmune disorder where HLA-B27 is positive, just like ankylosing spondylitis. It is treated by disease-modifying anti-rheumatoid drugs. And this condition is a misnomer. But if they talk about multifocal osteomyelitis, mark SAPHO syndrome more than sickle cell anemia, which can have salmonella infection causing multiple bone involvement. Hand infections. The most common hand infection is the infection of the nail bed called as paronychia. Most commonly asked MCQ is infection of the pulse space of finger called as a phelon or whitlow. Organisms, Staph aureus. Throughout orthopedics, Staph aureus. Also remember, the infection of the tendon sheath is called as infectious tenosynovitis, which has 4 signs called as the Canaval sign. Pain on stretch, uniform swelling, flexion of the finger, and the most specific is percussion tenderness along the tendon sheath. So these are the Canaval sign. Also remember one thing which I want you to remember, that in our hand, right? In our hand, you know, there is a space called as a radial bursa that goes around the thumb. Then there is a space called as forearm space of Perona, which communicates with the ulnar bursa, which goes to the little finger. So the infection of the thumb can go to the little finger with the forearm space of Perona, crossing it. Right, very nice. So this space is called as forearm space of Perona. Then you have a thenar space which has got the tendons of the index finger and the first lumbrical. So the index finger is separated and the infection for the thumb cannot go to the index finger. That's your MCQ. All right. And then the second, third, and fourth lumbricals, they are in the mid palmar space. Now, what I want you to remember, lumbricals, they do make a L in your hand, and this is called as lumbricals. And when the lumbricals, there are first two lumbricals supplied by the median nerve, the third and fourth are supplied by the ulnar nerve. When the lumbricals are paralyzed, opposite to it occurs called as a claw hand. In claw hand is hyperextension of MCP and flexion of interphalangeal joint. Lumbricals, flexion of MCP and extension of interphalangeal joint. Paralysis, this is called as claw hand. So in the claw hand, when you try to apply a splint, this is called as bending the knuckles and knuckle bender splint. So median nerve palsy, ulnar nerve palsy, or both can cause claw hand treated by the knuckle bender splint, which is bending the knuckles. All right. So this is something which is very, very important. Again, reminding, peronuchia is the most common infection of hand, infecting the nail bed. Phelon or vitlo is the pulse space. Thenar space, index finger tendons. Mid palmar space, the second, third, and fourth lumbricals or their tendons, right? Mycetoma, most common symptom of orthopedics is pain. Two conditions which are painless are mycetoma, which is subcutaneous infection, all right, occurring in the foot, called as a Madura foot, or occurring on the jaw or the mandible, called as the actinomycetoma, all right. So mycetoma is a condition where you have painless swelling, multiple discharging sinuses, and from that the discharging colonies are seen. They are usually the fungal colonies. On MRI, you will see dot in the circle sign, right? This is one condition which is painless. The second painless condition, which is seen in diabetics in the foot again, called as the diabetes mellitus, called as the Charcot's joint. So these are two painless conditions which one must remember, which are very, very important for you. If I take the message of biopsy from the investigations and Staph aureus from the infections, from tuberculosis, the message is it's a two vertebral disease. Tuberculosis of bone and joint is coming as a secondary disease from the lungs or the lymph nodes. Remember, it is paucibacillary, difficult to isolate. Also remember, hematogenous, right? So the organism will come through the blood, but difficult to pick up on the cultures. When I look at order of involvement, S, H, K, spine, hip, then knee. Because it comes from lungs, so spine, then hip, then knee. S, R, K, Shah Rukh Khan, S, H, K, spine, hip, knee. That's how you remember. Tuberculosis of shoulder is dry, called as Keri Sicca. Tuberculosis of the fingers, right, is called as spina ventosa. And this is the only one that can cause the periosteal reaction. Tuberculosis does not cause periosteal reaction, right? It usually involves the joint. The only one which can cause is the fingers, called as spina ventosa. Remember, tuberculosis involves the anterior part of the vertebrae, right? As the infection comes to the blood, the lower half of upper vertebra, upper half of the lower vertebra, they arise from the same mesodermal somite. So they have the same segmental artery. That is why tuberculosis will always involve two contiguous vertebrae. It's a disease which is anterior to the spinal cord. So it's called an anterior disease. That is why posterior elements involvement, right, and a single vertebral disease involvement is very rare in TB. It's common in malignancies. If I look at a vertebra, every vertebra has two eyes, the pedicles, and one nose, the spinous process. And the malignancies, they will destroy the pedicle. This is called as a winking owl sign when it destroys one, or when it destroys both the pedicles, it's called as a blind bat sign. These are signs of METs. What does TB shows? TB will show paradiscal disease, reduce this space. So remember, X-rays, we did it in the first part when we were doing about the investigation. X-rays in TB will show laws of curvature earlier, but then it will show reduced this space. MRI can pick it up earlier. Remember, in tuberculosis, as the disease goes from anterior to posterior, so the first to get affected is the motor part, then the sensory, and the bowel bladder involvement is very rare. But if it gets involved, then it's an indication to become aggressive. TB spine, first symptom is pain, first sign is tenderness, first neurological sign is increased reflexes or clonus. TB spine management is followed on a middle path regimen, which says if required, you will operate. You will not have an approach to never operate. You will not have an approach to always operate. When will you operate is the point here. You will operate in 3 scenarios: bowel, bladder involvement, increasing deficit, or no improvement. All right. The 2 surgeries which can be done are to remove the anterolateral part of the vertebra or the anterior part of vertebra along with the bone grafting. Never ever touch the posterior elements in tuberculosis, right? Because anteriorly the disease has destroyed, and if you go from the posterior approach, it's going to be harmful. That is why it is always better, right, to go from the anterolateral anterior aspect of the vertebra. So remember, spine TB, anti-tubercular therapy where rifampicin is number 1 drug, plus surgery when indicated is called as the middle path regimen given by Professor Dr. S.N. Tolisa. Remember, in tuberculosis spine, there is loss of curvature, whereas tuberculosis of other joints, there is increased vascularity called as peri-articular osteopenia. Coming to tuberculosis of the hip joint. The tuberculosis of the hip joint most commonly starts from the acetabulum, but yes, on the upper end of femur, Babcock's triangle is the commonest area for the femur, but overall the acetabulum. The tuberculosis of stage 1 will cause proliferation of the synovium called as synovitis. Position is Faber with lengthening. This is most commonly asked MCQ. As the disease will progress, this synovium and the organism will destroy the cartilage called as arthritis, converting it into early arthritis with farther and less than 1 centimeter shortening. Less than 1 centimeter shortening is not easy to appreciate. So when they mention that patient has got farther with shortening, you assume it to be stage 3 called as late arthritis because that's more than 1 centimeter shortening. Stage 4, the femoral head gets destroyed, the acetabulum gets destroyed, the destroyed femoral head migrates from one part of acetabulum to other called as a wandering acetabulum. And finally, there is a fusion of the joint called as the fibrous ankylosis. When the disease fuses joint, it's called as ankylosis. When the surgeon does that, that's called as arthrodesis. We'll come back to it. Tuberculosis of the spine will cause bone-to-bone fusion called as bony ankylosis. Where tuberculosis of all the other joints will cause incomplete fusion called as fibrous ankylosis. Remember, fibrous is painful. Bony is solid and painless. All right. And remember, in tuberculosis, right, of the hip, first is Faber, then farther and wandering acetabulum. That's the order. Also remember, if there is tuberculosis of the knee joint, initially it will cause synovitis and knee flexion. There will be osteopenia, there will be pain, there will be limp. But as it keeps on destroying tuberculosis or rheumatoid arthritis, they will cause a deformity called the triple deformity. There is posterior subluxation of tibia, external rotation of leg, and flexion of the knee, remembered by the mnemonic PERF. Posterior subluxation, external rotation, and flexion, PERF. So this is what you should remember, my friends. And one more thing is about the arthrodesis ankylosis. We'll just come back to it, right? Remember, the term for arthrodesis means surgical fusion, not a preferred surgery. What is a preferred surgery? Joint replacement. For example, if you want to replace the hip, right, complete hip means the femur side and acetabulum, it's called as a total hip replacement. Or if you just want to replace the femoral side, it's called as a hemiarthroplasty. There are 2 types of hemiarthroplasty. The one which has got 2 holes called as Austin Moore. Iski spelling mein 2 O aate hain. The second is Thompson's, which does not have a hole. Remember, Thompson also has 2 O's, but the 2 O's don't come together. I marked this wrong in one of my exams. All right. When you have replacements, they can be cemented, which are done for weaker bones and are cheaper, or it can be uncemented, where the bone integrates with the implant and is a longer half-life, but it has to have a normal bone. So younger individuals, which one will you do? Uncemented replacements. All right. Remember, arthrodesis is not a preferred thing. Replacement is a preferred thing if the joint has got destroyed. But sometimes if you have no other choice, you open the joint, remove the cartilage, get the bone in contact with the bone and fuse it. And this fusion can be done in the hip by using some plates, like cobra plate is the shape of the cobra, right? The plate has a shape of a cobra, so it's called as a cobra plate. And here what happens is there's a fusion. What causes the fusion? The surgeon, so arthrodesis. Advantage, painless. Disadvantage, no movement. If the same thing is done by a disease, it's called as ankylosis. It's a pathological fusion. Fibrous ankylosis, right? Fibrous has F. It is painful. It also has R. It is seen in rheumatoid arthritis. Whereas bony ankylosis is solid, is painless. S for solid, S for septic arthritis, S for solid, S for spine tuberculosis, or S that ankylosing spondylitis. So if I look at tuberculosis, peripheral joints, fibrous ankylosis, that is hip and knee, spine, bony ankylosis, joints, rheumatoid arthritis as fibrous, and ankylosing spondylitis as bony. This is an extremely, extremely important flow chart. All right. Now, bone tumors is something that is going to come to you in the exam. The first thing, remember that benign tumors, they are well defined, they know their territory, and they have a uniform feel. What is the feel? Hard is the bone, firm as cartilage, soft tissue. So a benign tumor, if it comes from the bone throughout hard, from the cartilage throughout soft, firm, and from the soft tissue throughout soft. Whereas a malignant tumor, because of variable rate of destruction, aggressiveness, somewhere hard, somewhere firm, somewhere soft. This is what is important. Benign tumors, well-defined margins, uniform consistency. Malignant tumors, ill-defined margins and variable consistencies. We did it in an area earlier that epiphyseal tumors, the two to remember, chondroblastoma and giant cell tumor, where I told you chondroblastoma is purely epiphyseal, but giant cell tumor, because of its spread, can also go into the metaphyses. The second point that you should remember, that in epiphyseal tumor with calcification is chondroblastoma, because cartilaginous tumors, they will calcify. If you look at the upper end of humerus, it's known for two things. Number one, the simple bone cyst, or also called a unicameral, single camera, one cavity, single cameral bone cyst, unicameral bone cyst, more than the chondroblastoma. That's upper end humerus known for. Also, one more difference. Unicameral bone cyst is something which is in the metaphyses, whereas chondroblastoma is something which is in the epiphyses. So one more thing that should help you. Also, chondroblastoma will have a calcification, which is not a characteristic feature of unicameral bone cyst. So upper end humerus, epiphyseal with calcification, chondroblastoma. Upper end humerus, metaphyseal, unicameral bone cyst. Coming to next, metaphyses is most common area for infection and tumor, and the king here is osteosarcoma, and diaphyseal tumors are vowels, osteoma, adamantinoma, Ewing sarcoma. We have a beautiful love triangle here. What you need to remember is that the epithelial tumor, not epiphyseal, epithelial tumor occurring in the tibia is called as adamantinoma. In the mandible is called as ameloblastoma. Both have the same histopath, but according to the bone, they have a different name. It's an exception. Remember, the biopsy decides the name, but here the location decides it. So this was decided in 1985 that a tumor of the epithelium in the tibia is adamantinoma, in the mandible is ameloblastoma. Now, what is the love triangle? The love triangle is that ameloblastoma loves mandible, but mandible loves squamous cell carcinoma. So the most common tumor of mandible is squamous cell carcinoma, but the most common location of ameloblastoma is mandible. So ameloblastoma loves mandible, mandible loves squamous cell carcinoma. When you look at the age of the tumor, although the part which we just did, epimetadia or the different bones, is more important than the age, but when you look at the age, the first decade, very rare age, Ewing's is very common. But you know the second love triangle, Ewing's sarcoma, second decade is more common than the first. Because if you have 100 Ewing's, 10 will occur in first, 90 will occur in the second decade. All right. But if there are 90 Ewing's in second decade, there are thousands and thousands of osteosarcoma in the second decade. That is why first decade, the king is Ewing's, second decade, the king is osteosarcoma. Right. Remember, after skeletal maturity, that is 1816, 1816, 1816. So usually 20 to 40 years, giant cell tumor is the king. And beyond 40, the two most common tumors of the bone, metastasis followed by multiple myeloma. And remember, in metastasis, the order is BPL, breast, prostate, and lung. This is the order. And the most common area where the Mets goes is the dorsal spine or the thoracic spine. This is what the Harrison says. When you treat a tumor, if it's a cystic cavity, open it, curate it. Curate means dry mopping, called a jharu lagana. If the particles are sticking hard, add a chemical to kill the cells. That's called as extended curettage. So curettage is only dry mopping. Extended is adding some chemical to it. Most common chemical added is phenol. That's what you use, right? The phenyl or the phenol in orthopedics. The best chemical which has the least rate of recurrence with extended curettage is liquid nitrogen. All right. And then the surgeries, we are a surgical branch. The surgeries which remove the tumor are called as excision. If you just remove the center, intralesional. If you remove to the pseudocapsular, called as the marginal. If you remove a normal cuff of tissue that is 3 centimeter all around, called as a wide local excision. And if you remove the entire bone of the compartment, radical excision. Which is the most common one? Wide local excision. So curettage is done for unicameral bone cyst. Extended curettage is done for chondroblastoma, aneurysmal bone cyst, and chondroma, or a giant cell tumor. This is aneurysmal bone cyst. This is unicameral bone cyst. So these are the surgical options. So benign and cartilaginous tumors operated. Most common surgery, wide local excision. Cystic lesions, curettage, unicameral bone cyst. With chemicals, extended curettage. Most common, phenol. Liquid nitrogen, best. 4 conditions: aneurysmal bone cyst, chondroblastoma, giant cell tumor, and chondroma. Malignant tumors, neoadjuvant chemotherapy, followed by surgery, followed by adjuvant chemotherapy, which is given after. Ewing's is the most radiosensitive bone tumor known to the mankind. But even then, the treatment for Ewing's sarcoma and osteosarcoma is neoadjuvant chemotherapy followed by surgery followed by adjuvant chemotherapy, although it melts like snow with radiotherapy. But remember, Ewing's radio is not the primary modality. Remember one more thing, cartilaginous tumors, only the surgery works. So cartilaginous tumors are chemo and radio resistant. So chondrosarcoma, you don't give chemo and radio. So it's only surgery, wide local excision, right? Single central cavity, unicameral bone cyst. The fallen cortex will break and fall in the center of the cavity, called as the fallen leaf sign. It also has a radiological sign where the cortex moves up and down, called as a trapdoor sign. Multiloculated eccentric sign, right? This is called as aneurysmal bone cyst. Multiple loculations, multiple parts. All right. So this is called as aneurysmal bone cyst, blood filled. Night pain relieved on taking aspirin or salicylates, osteoid, osteoma. Sometimes it disappears on aspirin. All right. Large to feel, small on x-ray. So there is a bone with a bony growth, which is near the joint before the skeletal maturity. Right, and this bony growth is covered by a cartilage. So when you touch it, you will feel the bone and the cartilage. But when you click an X-ray, you will only see the bone. This is called as large to feel, small on X-ray. Bone covered by cartilage, osteochondroma. And then epiphysis with calcification, chondroblastoma, also called as Codman's tumor, which is not the Codman's triangle. Codman's triangle is a periosteal reaction in malignant lesions like osteosarcoma. Codman's tumor is another name for chondroblastoma. And then the most common tumor of bones of hand and feet, and chondroma. Most common tumor of hand is squamous cell carcinoma, remember. But most common tumor of bones of hand and feet is chondroma. Right? So this is what we are doing. Unicameral bone cyst. Single central cavity, upper and humerus, with a fallen leaf sign. Multiloculated eccentric in the metaphysis is aneurysmal bone cyst. In the diaphysis and in the cortex of the bone, right? Lytic lesion with surrounding sclerosis, called as a nidus in osteoid osteoma. Remember that, you burn it, you finish it. This is important. Also remember that this is the only tumor for which CT scan is carried out, because all other tumors, MRI is very, very good. All right. Osteochondroma or exostosis, it is not a tumor, it's a developmental abnormality. It grows away from the joint, has a covering of the cartilage over it. So large to feel, small on X-rays. All right. This is osteochondroma. Then you have epiphysis with calcification, called as a Codman's tumor. If you have a tumor of bones of hand and feet and chondroma, there is hyaline cartilage in it. There are 2 syndromes with it. Multiple enchondromas, that is only enchondromas, is all ears. Multiple things, many things is Mafusi, which has got enchondromas hemangiomas, and phlebolith. Phlebolith is calcified superficial veins, is calcified superficial veins. All right. So there is hemangiomas and chondroma. So this is something which is extremely important. This image can come for Mafusi to you. All right. Then comes a tumor which can go till the joint as the joint. All right. The most common tumor, right, that can involve the cartilage, according to Robbins, is giant cell tumor of the bones, right? And tumor of the lower end radius is GCT. So here comes the third love triangle. The first love triangle, ameloblastoma, loves mandible, but mandible loves squamous cell carcinoma. The second love triangle, first decade likes E-wings, but E-wings loves second decade. The third love triangle, lower end radius like GCT, but GCT loves lower end femur. So the most common location for GCT is lower end femur. Remember, lower end radius going till the joint, upper end tibia going till the joint, upper end femur going till the joint or till 1.5 centimeter of the joint. It is giant cell tumor. All these images, they have been asked to you again and again in the exam. Question asked to me, how do you differentiate GCT with ABC? Remember, giant cell tumor is after maturity going till the joint. ABC is in the metaphysis before maturity. Remember. So this is something which is very, very important. So metaphyseal, giant cell tumor is going till the end of a bone. Giant cell tumor after maturity. ABC before skeletal maturity. So you will see the growth plate here. So it will be below that. So it's in the metaphysis. That is what you should remember. When another developmental abnormality apart from osteochondroma, fibrous dysplasia. Here, the classical shape of the bone changes because the bony matrix is substituted by the fibrous matrix. This is called as Shepherd-Crook deformity at the upper end of femur. All right. In this condition, the bone appears like a ground glass, grazy appearance, ground glass appearance, or there can be a sclerotic lesion at the upper end of femur called as a Rind sign. So you have Rind sign, ground glass appearance, or fibrous dysplasia causing Shepherd-Crook deformity. The crooked stick a Shepherd holds. McAkuhn-Albright syndrome is a combination of three things: multiple fibrous dysplasia, that is polyostotic fibrous dysplasia, precocious puberty, and pigmentation, that is coffee colored spots. So 3 P's: polyostotic fibrous dysplasia, precocious puberty, and pigmentation. These are seen in McAkuhn-Albright syndrome. This is a question that's been coming into INICT for last 2 years. Histiocytes, they proliferate and they destroy a bone called as eosinophilic granuloma. When they destroy multiple organs, all right, it's called as a Hand-Schüller-Christian disease, and right, and when it destroys the entire human being, it's called a Litter-Sway disease. So Litter-Sway disease is fatal. Hand-Schüller-Christian disease is something which is called as exophthalmos, diabetes insipidus, and the lytic lesion. But eosinophilic granuloma or histiocytosis X is one lesion, either into a lung or the bone. It is a cause of the beveled lesion of the skulls. Beveled means sloping. In this lesion, you have a cells with granules, and these granules, called as Burbeck granules, have the tennis racket appearance. So it is not the cells with the tennis racket appearance, the granules have a tennis racket appearance. And you know, anything that goes away on its own is an MCQ. So that is spontaneous resolution is seen in eosinophilic granuloma. So they will give you a history that there is a lytic lesion and the cells will have a grooved nucleus or will have the Burbeck granules or tennis racket appearance. That is what you should remember. This is histiocytosis. Another image-based question or image-related question, vertical striations in a vertebra called as the corduroy appearance, the pattern of a cloth or the jail bar pattern is seen in hemangiomas. The hemangiomas, when they do a CT scan, will have unequal dots called as polka dot sign. When you look at sacrum, sacroiliac joint is known for ankylosing spondylitis, but sacrum per se, lysis is known for a disease called as chordoma. Chondroma nahi hai, chordoma. Chordoma is arising from the notochordal remnants, extremes of spine, either the base of the skull or the sacrum. And they have got cells, the physalliferous cells, which have vacuolated cytoplasms. So physalliferous cells are seen in is a question chordoma. Chordoma arises from the notochordal remnants and is the most common cause of lytic lesion of a sacrum. Coming to the malignant tumors, you know, in malignant tumors you have 3: the chondrosarcoma, which is mainly in the femur and pelvis. You have osteosarcoma, which is in the metaphysis, in the cancer of the youth, It is a radio-resistant bone tumor, and it is also a tumor which comes back after radiotherapy. You give radiotherapy for any reason, and after 10 to 15 years, you will see it. It's a tumor which is seen in lower end femur. So lower end femur is known for three things: osteomyelitis, giant cell tumor, and osteosarcoma. It's a tumor which is a bone-forming tumor, homogeneous calcification. It is associated with retinoblastomas. It's a tumor known for pain and night pain. Remember, pain, osteosarcoma. Night pain, osteosarcoma. Night pain relieved on taking salicylates is osteoid osteoma. So that salicylate word is important. Otherwise, the most common tumor known for pain and night pain is osteosarcoma. You have Codman's triangle, or you have a sun ray appearance coming into it. And remember, in this tumor, the extent decides the prognosis. What is the extent means? It means the staging. Pulmonary mets are poor, but if it goes to other organs, it's even poorer, and you grade it according to low, intermediate, high grade. Remember, it destroys the lung and causes pneumothorax. Is a classical old age MCQ. You treat it with neoadjuvant chemotherapy followed by surgery followed by adjuvant chemotherapy. Remember, methotrexate is the key drug, and etoposide doesn't function in this, right? As more aggressive to that is Ewing's. The most aggressive bone tumor known to man is Ewing sarcoma. It has to be treated very aggressively, and it presents like osteomyelitis. Two tumors which present with pain, Ewing and osteo. Two tumors that present like osteomyelitis, Ewing and osteo. Two tumors which have poor prognosis, Ewing's more than osteo. Ewing sarcoma, in fact, is a tumor, right, which presents more in second decade than the first. But first decade, you don't have much. That's why Ewing is also the most common bone tumor of the first decade, right? So there's a love triangle. First decade likes Ewing's, but Ewing's like second decade. Femur diaphysis, Ewing's. Femur lower metaphysis, osteosarcoma. It is a tumor of the marrow cells. That's why you need to see the marrow biopsy. It's more of a systemic disease. Ewing's is more of a systemic disease. That's why it kills very rapidly. That's why if a child comes with osteomyelitic presentation, go aggressive, get the senior most person, get a diagnosis, right? The genetic defects in Ewing's, all right? Ewing's is a round cell tumor. It's glycogen positive cells. Ewing's is a tumor where CD99 is a specific marker, MYC2. Ewing's has a translocation. The larger digit will always come second, 1122, 2122, 722. But 1122 is the number one asked. It can have trisomy 8, which is an MCQ, and trisomy 12 coming to it. In Ewing's, you have destruction of the bone. So bony onion peel appearance. There's destruction of extending into soft tissue. So there is bony and soft tissue component both. Poor prognostic factors are the factors which shows that there is osteomyelitis. In fact, like high ESR, high TLC, fever. Ewing's has even poorer prognosis. If there's a metastasis occurring, if the chemotherapy, which is the main agent for treatment, not working, or there is a relapse. Remember, you treat Ewing's by preoperative chemotherapy, then surgery, then chemotherapy after that, neoadjuvant chemotherapy, surgery, adjuvant chemotherapy, radiotherapy may be given. So it's the most radiosensitive tumor known to mankind, but still radiotherapy is optional. So first decade with onion peel appearance, with diaphyseal appearance, Ewing sarcoma. Second decade more than first is for Ewing's. Second decade metaphyseal component with Codman's triangle, sun ray appearance is osteosarcoma. All right, these are two key lines by which MCQs will come to you. Breast, prostate, lung is for Mets more than dorsal spine, and the lytic lesions of multiple myeloma will cause, right, because of plasma cell destruction, will cause punched out lesion on the skull. Multiple myeloma is a tumor of the plasma cells. Normally, when the bone destruction occurs, the osteoblast will come and repair it, but it's a tumor, so the osteoblast will not come and repair it. That's why alkaline phosphatase is negative. Bone scan is normal, negative, because bone scan indicates osteoblastic activity, and osteoblastic activity will always synthesize which chemical? Alkaline phosphatase. So this is something that you should always remember. So multiple bone pains with high ESR going more than 100, with high calcium, that's multiple myeloma. Remember, there will be M proteins in serum and urine, bone marrow, plasma cells or localized lesion called as plasmacytoma. There will be end organ damage causing lesions in the bone, low hemoglobin, deranged kidney, high viscosity, high calcium, more than 2 infections per year in the bacteria, or amyloidosis. Punched out lytic lesion of the skull is a feature of multiple myeloma, right? And when the plasma cells spread and destroy the entire human being, is called as a plasma cell leukemia, and that's more than 20% cells in the peripheral smear. When you look at the different types of skulls. There are skulls which are lytic skulls, so they can have beveled lesion seen in eosinophilic granuloma. They are the sloping or the beveled lesions, or they can have large lytic permeative lesions seen in Langerhans cell histiocytosis. There can be a salt and pepper sprinkling on the skull seen in hyperparathyroidism. Or they can be punched out lesions of multiple myeloma. But there are some more skulls that one should remember. The two of them are Paget's, where there are cotton wool deposits or a large area of osteoporosis. Depending on the osteoblastic activity of Paget's increased, causing cotton wool skull. Lytic activity increased, causing osteoporosis circumscripta. In fact, there's a separate type of hat which is there in Paget's, called as Tam O'Shanter hat. So Tam O'Shanter skull is also seen in Paget's. Paget's is a disease where the skull size keeps on increasing because of osteoblastic activity increment causing cotton wool skull. So this is a disease of increasing hat size. What is another disease for increasing hat size? Even more common than Paget's? Good, acromegaly. And then hair on end appearance, that is, you will see that there is a hair on end appearance in hemolytic anemia like thalassemia. So these are the conditions which you should remember when you're looking at different skulls. Nerve injuries, short, strong topic. Seddon's classified nerve injury into three types. He said neuropraxia is 100% recovery. So a patient slept on the edge of a chair and had a radial nerve compressed here, had a wrist drop. All right. After some weeks, he's had a complete recovery. So it comes back like a moment, like a love. जैसे प्यार एक बार में होता है, love happens in a fraction. Similarly, neuropraxia recovers in one moment, in one go. So when there is 100% recovery, that's neuropraxia. When the recovery is proximal to distal, right? This is called as motor march, right? For example, first the elbow extension, the radial nerve comes, then the wrist, then the finger. This is called as axonotmesis. And when there is no recovery, this is called as neurotmesis. Remember, when the nerve recovers 100%, it means it's a physiological block. This is neuropraxia. Tinel sign is negative. Tinel sign means damage to the axon sheath. All right. When the axon sheath recovers, tinel sign is positive and progressive. And when there's a complete nerve transaction, it means the tinel sign will be positive but will not recover. So static. So actually the nerve recovers. The nerve recovers at what rate? 1 mm per day is a good rate of nerve recovery. And which is the test for doing that? Electromyography. If I look at the clinical presentation of the nerves in the area involved, around the shoulder, the axillary nerve is damaged, and there is an area called a regimental badge area where the army people put their badges. The sensory loss occurs in that area called a regimental badge sign. Around the shaft of humerus, that is radial nerve palsy. The radial nerve palsy occurs at the junction of upper 2/3 and lower 1/3 more than the spiral groove. Remember that. So radial nerve palsy occurs at the junction of upper 2/3 and lower 1/3 of humerus, called as Holston-Lewis sign. This is important for you to remember, and the radial nerve palsy will have a wrist drop. The sensory loss in the first web space, very insignificant. It's mainly a motor nerve, and radial nerve palsy is the most common nerve palsy seen in clinical science. Right? Coming to next, behind the medial epicondyle, the ulnar nerve, supplying the third and the fourth lumbrical. The action of lumbricals is tuk. The paralysis is tum. All right, causing hyperextension of MCP and flexion of interphalangeal joint. This is an ulnar claw hand. And when you correct it with a knuckle bender splint, bending the knuckles. Whereas in the wrist drop, you do it by uplifting it, called as a cock-up splint for the radial nerve palsy. So similarly, for median nerve, it is around the wrist joint, causing the claw hand on first two fingers. Further, friends, around the head of radius, there is a nerve called as Puschien-Tosch's nerve, which is a pure motor branch of radial nerve, and it causes loss of finger extension of MCP, causes finger drop. So coming again, around shoulder axillary nerve, regimental badge area. Around humerus, radial nerve, wrist drop, correction by cock-up splint. Behind the medial epicondyle, ulnar nerve, ulnar claw hand, correction by knuckle bender splint. Around the head of radius, the Puschien-Tosch's nerve, pure motor branch, finger drop. Around the wrist, the median nerve causing the medial claw hand and other signs, we will talk about it. The knuckle bender splint, and if we talk about knuckle bender splint and ulnar median, both are given. Ulnar is more common than median, so ulnar more than median. And then around the hip, the sciatic nerve. Around the knee, the neck of fibula, the common peroneal nerve causing the foot drop. Also remember that the sensory supply, the tip of index finger is supplied by the median nerve. The little finger is supplied by the ulnar nerve, first web sway by the radial nerve. Electromyography is the best test for nerve recovery, and nerve recovers at what rate? 1 mm per day. Action of lumbricals, paralysis claw hand, knuckle bender splint is something you should remember. Coming to the ulnar nerve. When you look at the ulnar nerve supplies the palmar interossea which adduct, dorsal interossea which abduct. So if you give a card to a patient and ask him to hold it between the fingers, this is called as a card test, palmar interossea adduction, ulnar nerve injury. Alright. Similarly, the thenar eminence muscle adductor pollicis by ulnar nerve. So if you give a book to a patient, ask him to hold it between the thumb and the palm, this is called as a book test. But if the ulnar nerve or adductor pollicis is paralyzed, you will flex the thumb and hold the book. This is called as a Froment sign. Remember the mnemonic, Froment sign, ulnar nerve is mnemonic, F-U, Froment sign, ulnar nerve. The abducted little finger is Wartenberg sign, and when you cannot move your middle finger to either side, right, loss of abduction, it means dorsal interossea gone. This is called as Igawa test. So all these are tests for ulnar nerve. Similarly, when I talk about median nerve, the flexors of the first two fingers are supplied by the median nerve because FDP lateral half and all the flexor pollicis longus are supplied by the median nerve. So when you make a fist, these two fingers stand out, called as a pointing index. When a pope speaks to a very big community, that's how he talks. This is called as a benediction attitude. Similarly, when I clasp both my hands, these two fingers stand out. That is called as Ochsner clasp test. They all mean the same thing, that the first two fingers are not flexing by the median nerve. If I look at the abductor pollicis brevis, which is supplied by median nerve, if you touch the pen like this is called as a pen test. It came as an image in the exam for the median nerve. Remember, the opposition is a function by median nerve, and when it's paralyzed, the median nerve is gone, the thumb is in the same plane as palm, called as the ape thumb deformities, because human beings, the thumb is anterior, giving an advantage to work with fingers. In monkeys, it's at the same level. Remembered by the mnemonic, the name I have, AM, because I make you do things like monkeys. So, Apurv Mehra, ape thumb, median nerve. And remember, the median nerve is a branch called as anterior interosseous nerve, which supplies three muscles: pronator quadratus, flexor pollicis longus, FDP lateral half. So this sign, called as a Wow or a Kilo Nevin sign, indicates that anterior interosseous nerve, a branch of median nerve, is functioning very well. All right. Remember that the median ulnar nerve paralysis will cause hyperextension of MCP and flexion of interphalangeal claw hand, and then correction is called as a knuckle bender splint, ulnar more than median. When I look at the radial nerve, it is called as a crutch palsy, honeymoon palsy, or the Saturday night palsy. The radial nerve palsy, all right, will cause loss of the sensation of the first web space and will cause the wrist drop. Radial nerve is the most commonly damaged nerve, and whatever things are common, they usually have very good recovery. So it also has a fantastic recovery. Remember, the radial nerve is classified into high and low just on the basis of paralysis of a muscle called as brachioradialis. So in high radial nerve palsy, brachioradialis is paralyzed. In low, it is not. In high, you have wrist drop. In low, you have wrist drop. In high, you have finger drop. In low, you have finger drop. In high, you have sensory loss. In low, you have sensory loss. So it's the same. Everything is same except for the brachial paralysis, and that's why, right, you have to understand it's more of a theoretical differentiation. When you are talking about a posterior interosseous nerve, a pure motor branch nerve, there's only a finger drop, no sensory loss, and superficial radial nerve, which supplies the sensory area, sometimes supplies the wrist extensors. All right. Remember one more thing here. Sometimes they ask you a question, patient presents with a wrist drop with no sensory loss. Which nerve is involved? And people mark it as posterior interosseous nerve. It's incorrect, because wrist drop only occurs in radial nerve palsy. It does not occur in posterior interosseous nerve palsy, because posterior interosseous nerve palsy will have intact extension of the wrist, but finger drop will occur. All right. Now, when you have brachial plexus, you have C5, C6, C7, C8, and T1. C5 and C6 are the main areas which supplies shoulder abduction and elbow flexion. So in Erb's palsy, C5, C6 nerve roots are blocked, causing loss of shoulder abduction and elbow flexion. So movements which are lost are flexion of elbow, abduction and external rotation of the shoulder, and supination of forearm. So Fabers are the movements which are lost in Erb's palsy, whereas Klumpke's palsy, which involves the C8 and T1, will have claw hand, and when they have a claw hand, they also have plus minus Horner syndrome with it. All right. What you need to remember here is Erb's palsy is more common, has better prognosis. Also remember Erb's palsy, because it doesn't have elbow flexion or shoulder abduction, it has a waiter tip or policeman tip deformity, which is shown here, which has not come as an image in any exam till now, is one of the hot shots that can come to you. All right. When the nerves are entrapped in closed pieces, it's called as entrapment syndrome or compression neuropathies. The commonest is median nerve palsy, called as carpal tunnel syndrome, which has got inverted namaskar, or the phalanx test, or a straight namaskar called as a reverse phalanx test. The most common cause idiopathic, can be associated with some fractures, arthritis, hormone disorders, or pregnancy, and is more common in females. All right. Some more compression neuropathies are thoracic outlet syndrome, where C8 and T1 is more commonly involved. Nerve roots are involved. It has got tests which stretch these, and you look for the pulses, called as Adson's test, the Roos test, where you keep doing this and you will feel the numbness, or the Wright's test. These are the tests for thoracic outlet syndrome. And then you have something called an Allen's test, where you compress the radial or the ulnar artery and see the patency of the circulation. It came as a video in one of the exams. This is called as an Allen's test. When you have got compression neuropathies, their treatment is Plan A. What is Plan A? It's a name I have given. Rest plus NSAIDs. That is, give rest to the patients and anti-inflammatory drugs. If not relieved, you inject in that area, called as local steroids. If not relieved, you do a surgical decompression. So this is what you do it in compression neuropathies. When we look at trauma, number one question is, what is a sure sign of fracture? So abnormal mobility. What is mobility? At the joint. But if, right, there is a sure sign of a fracture, there will be abnormal mobility at the fracture site. So normally the forearm does not move. The wrist moves or the elbow moves. The same version, if I rotate my hand, the movement of rotation will go from forearm to the elbow. But if there is fracture, the movement will be transmitted at the fracture site and will not go proximally. So this is failure to transmit the movement proximally. Both mean the same, but in the order you will choose. Again, crepitus means sounds from the fracture ends. If the first two are not there, then you will choose crepitus. It should not be the first option, because it can cause neurogenic shock. Now, which is the most consistent sign? That's tenderness. Consistent sign is a tenderness. Then there's a fracture. There's a most common fracture in the bone. In the body is clavicle. At the birth is clavicle. In children is radius more than ulna. Most common joint to dislocate is shoulder anteriorly. You know why? Because the head is 4 times the glenoid. So it's like a golf ball on a tee, right? Most common dislocation in children is elbow, and it goes posterior. Apart from shoulder, all go posterior. Rarest to dislocate is ankle, and because the ankle does not dislocate, it causes the ligaments damage around it, called as the sprain. Anterior talofibular ligament is the most common ligament damage in the body. Similarly, the tendon injuries, if you want to look at, the most common tendon injury in human body is supraspinatus, followed by biceps, followed by tendoachilles. You thought tendoachilles is the commonest? No. Supraspinatus is the commonest. Now, when there is a fracture, there is blood around it, called as hematoma. If you preserve the blood in and do not allow to go out of the skin, closed fracture. If it breaches the skin, goes out, open fracture. So the bone need not go out. Even if the hematoma around the fracture goes out, it means the same, because it's very rich in nutrients and cells for the bone to unite. On this, the granulation tissue comes. Over it, the immature bone or callus comes. Callus allows deformation but not allows displacement. All right. On this, the mature bone comes, called as consolidation, and finally it remodels. You won't find out where the bone fractured. Now, this stage of fracture healing is with an intermediate stage of callus, which is like a cartilage. So this is called as a secondary healing. Secondary, the spelling of secondary has a C in it. It means there is callus. Very, very important, and it's a very strong bone union. All right. When I look at the fractures like supracondylar humerus, which is away from the joint, I will take the patient to the operation theater, will not expose the fracture site or the hematoma, will reduce it under X-ray control, the C-arm, and this is called as close reduction and fixation, right? So that is what it is, close reduction, because the hematoma was not exposed. So extra-articular fractures, close reduced. Whereas if the fracture involves the joint surface like lateral condyle humerus, you need to reduce it like a jigsaw puzzle, otherwise arthritis or joint cartilage damage will occur. That's why in this case you have to open reduce, means open the hematoma, do not worry about losing it, but reduce the fracture site, compress the cartilage area and compress the bone so that they unite. So extra-articular fractures close reduced, intra-articular means to the joint open reduced. In supracondylar fracture humerus, a beautiful thing is there. Sometimes in X-ray, you can't see the bone fracture, but you will see the soft tissue elevation. This means the blood is underneath. This is called as a fat pad sign. And when it displaces, my friends, because of the pull of a muscle called as olecranon, it usually goes posteromedial or the extension side. So 98% of supracondylar fractures, they go into the extension on the posterior displacement. All right. So this is what I was talking about. Secondary healing. Secondary healing has a callus. All right. It is more biological and it is done in nailing. When you put a nail in the bone or when you apply a cast, when you apply a plaster of Paris, that is calcium sulfate half H2O. On one surface, it's a slab. When it goes around C, circumference is a cast. When this cast goes around the spine, it's called as spica, spine cast, spica. So in a cast, there will be some movement, callus will be formed. This micro movement form the callus. When this is micro movement, this callus will change into consolidation. But if this micro movement goes into gross movement, it will not unite. That's called as non-union. We will talk about it in a short while. So secondary healing, there is callus formation. There is cast in the nail causing secondary healing. Whereas primary healing means bone packed to each other, which is seen in a plate. So primary, P for primary, P for plate, and it doesn't have a C in the spelling, so no callus formation, right? Now remember that when I talk about non-union. So non-union is a bone which is not united in 9 months. Atrophic non-union, when the bone ends are avascular. You need to cut them, freshen them. So you need to put a bone graft plus fixation. Whereas hypertrophic is where there is macro movement, not allowing the bone to unite. So there is only stability required because bone graft is enough. There is a lot of callus. So is movement required for callus? Yes. Micro movements unites. Macro movements non-union. Which type of non-union? Hypertrophic. How will you treat it? Stabilize. Atrophic non-union, damage ends. Just like paprika sign, make them bleed. Put a graft because it requires for union. This is what is non-union. What are the examples of non-union? F, L, U, T, S. What is F? Femur neck. Doesn't unite. What is L? Lateral condyle humerus. What is U? Ulna. What is T? Tibia or talus. What is scaphoid? That is S. And the most common complication of scaphoid is non-union. Whereas most common complication of femur neck fracture is avascular necrosis. Remember, in femur neck, avascular necrosis is more common than non-union. Whereas in scaphoid, non-union is more common than avascular necrosis. And your books write opposite. Alright. Fractures undergoing malunion means they do not unite properly. Remembered by the mnemonic MISC. Malunion. I is intertrochanteric fracture femur. S is supracondylar humerus causing what? Cubitus varus. Whereas on the previous page, lateral condyle humerus will cause cubitus valgus. Also remember, it's also called as a gun stock deformity, the cubitus varus. And then comes Colles, which causes the dinner fork deformity. It's a fracture of radius or clavicle. The most common bone to fracture. So these are fractures undergoing malunion, not aligning in the normal, not uniting in the normal bone alignment of the body. Now, swimmers, the shoulder is the most common joint to get damaged, and subscapularis, the forgotten tendon, the lift-off test is being shown here. The shoulder dislocation is the most common dislocation. Remember, the head is down and the arm is out. So, it's called as down and out. Why it is the most common? Because 4:1 is the ratio of the head is to glenoid. So, this is 4 times to 1 time. All right. And also remember, in any anterior dislocation, whether hip or shoulder, the head will be down and out in anterior dislocations. The methods by which you test them. Normally, you should be able to touch the opposite shoulder, Dugas test. If you can't touch, it means Dugas test is there. Dur gaya, opposite shoulder. Or the circumference of the axilla. When the head comes out, the circumference of the axilla will increase, called as the Callaway test. Or if you place a ruler on the lateral epicondyle, it should go away from the acromion because the shoulder has a contour. When it dislocates, the ruler will touch both the points, that is the lateral epicondyle and the acromion. Hamilton ruler test. All right. Similarly, you have a Brand's test that talks about the vertical height of the axilla. So these are all the tests which are for shoulder dislocation. The methods to reduce, classical is Scotcher's maneuver, multiple steps in it, or gravity reduction called as Stimson's maneuver, or the Hippocrates maneuver, where you put the patient on the ground and put your heel in the axilla, which is not to be done. All right. So Hippocrates and Stimson are not the preferred ones. The Cochers is the most common maneuver. All right. When the shoulder is unstable anteriorly, if you do abduction externation, the head will come out. So this is a test for the shoulder instability anteriorly. This is called as the apprehension sign. All right, or the anterior draw test, or the fulcrum test, or the crank test. Whereas opposite, when you put it posteriorly, adduction intonation, it is called as a jerk test. And when you try to pull it inferiorly and there is a sulcus beneath the acromion of the head, it is called as a multi-directional instability, or the sulcus test. All right. When I look at the anterior dislocation, which is the most common, so anterior instability is the most common, because the most common complication of a shoulder dislocation is a shoulder dislocation again. The second common is the axillary nerve damage. All right. Why will a shoulder dislocate again? Because while dislocating, it can cause 2 lesions. The number 1 common lesion it can cause is damage to the anterior part of glenoid labrum. If anterior is not given in the question, you can choose the anteroinferior part of glenoid labrum. And the number 2 is a posterolateral defect in the head of humerus. This is called as the Hill-Sachs lesion. Now, when there is a posterior dislocation, it used to have a scenario of either electric shock or epilepsy. Also remember, the head will be at the level of the joint and the arm is adducted up and in. There is electric bulb shape head, or the glenoid is empty because the overlap of the head on the glenoid goes away because it's internal rotated. Remember, shoulder dislocation posteriorly is the most common missed dislocation in the human body. Anterior dislocation is marked appearance. Down head, out, down and out, whereas posterior is up and in. All right. Also remember, in anterior dislocation, you will have Hill-Sachs lesion, that is a posterolateral defect in the head of humerus. Whereas in a posterior dislocation, you have reverse Hill-Sachs lesion, that is in the anteromedial aspect of the head. Now, when you look at a patient of epilepsy, right, which is the most common dislocation? This is a question. Could. Even in epilepsy, the most common dislocation is anterior more than posterior. But whenever you see a posterior dislocation, think of epilepsy. It's a triangle. All right. Going to next. When I look at the common injuries and their presentation, shoulder will have axillary nerve damage, regimental badge sign. Humerus will have radial nerve palsy, wrist drop. Supracondylar humerus, the 4 nerves are anterior interosseous nerve, causing inability to perform the Keelan-Evans sign, then the median, then the radial, then the ulnar nerve in this order. Elbow dislocation causing ulnar nerve damage, the claw hand and the ulnar nerve signs. Cubitus valgus in lateral condyle humerus, seen in lateral condyle humerus, gradual onset valgus, slow onset ulnar nerve palsy. Around the wrist, the median nerve is damaged. Around the hip, the sciatic nerve. Around the knee, the CP, and common nerve causing the foot drop. And this is what I was telling you about, the sign of Holston-Lewis, that at the lower 1/3 shaft of humerus, the radial nerve comes from the posterior compartment to anterior, it is fixed. And that's the area where it's more prone to get damaged as compared to the spiral groove, right? Whatever is fixed will get more damage, like the medial meniscus is more fixed in the capsule, more damage in the knee. Radial nerve at this junction is fixed at the lower 1/3, more damage. And then comes the Monteggia, which is a fracture of ulna with dislocation of radial head. And what goes around radial nerve? What goes around the radial head? The posterior interosseous nerve, a branch of radial nerve getting damaged here, causing finger drop. Fall on outstretched hand, like this guy, all right, can cause the fractures of the clavicle, cervical neck humerus, supracondylar humerus, which is the most common fracture of Fuchs in a child, lateral condylar humerus, radial fractures, Galeazzi, which is a fracture of radius with dislocation of the radial head, of the distal radioulnar joint, along with damage to the triangular fibrocartilage complex at the wrist joint. That's Galeazzi, and Galeazzi is 3 times more common than Monteggia. That's why more commonly as an example. Then Fuchs, most common fracture is Colles. Overall, it occurs in elderly. Then the radial styloid and the fracture scaphoid, which occurs in the young or the youth. So these 3 boxes you can't miss. Supracondylar fracture humerus will cause you cubitus varus, posteromedial displacement. Lateral condylar humerus will cause cubitus valgus. Supracondylar humerus, anterior-interosseous, median, radial, ulnar nerves involved. Lateral condylar humerus, tardial ulnar nerve palsy. Carrying angle is the angle between the arm and the forearm. Reduced carrying angle is cubitus varus. Increase is valgus. It's more in females because the trochlea in females is at lower level. Supracondylar humerus causes the cubitus varus or gunstock deformity, shown as an image. Lateral condylar humerus causes cubitus valgus and tardial ulnar palsy, shown in the image. 3-point relationship at elbow is medial epicondyle, lateral epicondyle, and tip of olecranon. They form a triangle in 90-degree flexion of elbow. They are maintained in supracondylar humerus fractures. They are lost in elbow dislocation, right? When you have supracondylar humerus fractures, you have 2 types of tractions that one must remember. One is a Smith and a Dunlop. I'll talk about Smith fracture shortly, but remember, the Smith traction is for supracondylar humerus, it's not for the Smith fractures. So Smith traction is for supracondylar humerus, it's not for the Smith fracture. So Monteggia is a fracture of ulna with dislocated radial head. The damaged nerve is posterior interosseous nerve. There is a surgery for it, Bell-Tosse procedure. Galeazzi is a fracture of radius with damage to the distal radioulnar joint, along with the triangular fibrocartilage complex at the wrist. Which is more common? I told you, Galeazzi. Similarly, when you look at the Colles and the Smith, the Colles fracture, there is a fracture of the distal and radius. If this is first metacarpal, it goes posteriorly. The distal fragment goes posteriorly, remembered by the mnemonic Priyanka Chopra. And that is why in Colles fracture, you have a dinner fork deformity. All right. So it undergoes malunion. Whereas Smith, the fracture goes anteriorly at the first metacarpal or thumb, it goes anteriorly. So it leads to the garden spade deformity. So that's what it is there. Remember that Smith fracture is extra-articular with anterior displacement, garden spade deformity. Colles is extra-articular fracture with posterior displacement, and Colles is classically a fracture of elderly. It has been described for osteoporotic individuals. You know which is the most common complication of Colles? Finger stiffness. Colles also can lead on to malunion into dinner fork deformity. Colles can also cause rupture of extensor pollicis longus tendon. Colles is known to cause carpal tunnel syndrome, and Colles can cause a complication called as high activity of sympathetic system called as Sudeck's dystrophy. We will talk about it. All right. When you have a child, being handled by a father and enjoyment is going on, a father might exert a pull while playing with a child on the elbow, where the radial head comes out of the annular ligament. This is also called as a nursemaid's elbow. Age group is 1 to 4 years. Father is the culprit. Mother is scolding the father. The child is crying with forearm in pronation. Treatment is simple OPD based, forceful supination. Some of the fractures around the wrist and the hand, when there's a fracture of only the radial styloid, it's called as a Schaufer's fracture. And when there's a fracture of the joint, that is the joint surface of radius with wrist movement, it's Barton's. And this is usually operative. Barton's is usually operative. Remember, my friends, in Coley's fracture, it is the conservative management usually, and the order of reduction is pronation, palmar angulation, and ulnar deviation, giving it a cast called as a hand shaking cast in Coley's. Normally, the rule of splint is if you apply a splint for forearm, it should go above the elbow and it should involve the wrist. So it is one joint below and one joint above. But Coley's is an exception where you apply a cast which is below elbow because it is usually associated with a lot of stiffness. Whereas Smith, which is opposite of Coley's, is an above elbow cast. When I look at the normal anatomy of wrist, right, the anatomical snuff box is an area where you have tenderness of the scaphoid, the base of first metacarpal and trapezium. Remember, the scaphoid is the most common carpal bone to fracture. They show you an image, it fractures at the waist usually, and it is usually treated by a glass holding cast. The blood supply of the scaphoid is such, it goes from the distal to proximal, and that's why when it fractures here, the proximal fold can undergo avascular necrosis and the dead bone is white as shown here. So hand shaking cast is Coley's, glass holding cast is scaphoid. When I look at the fractures of the base of first metacarpal with the pull of a muscle with dislocation is Bennett's, and when there's a fracture with comminution without a dislocation, it's called as Rolando, and when there's a fracture of the neck of fifth metacarpal in a boxer's injury, it's called as a boxer fracture. Remember, Bennett's is also common in boxers, but boxer's fracture is more common. When the dislocations at the wrist occur, it is very different type of scenario. When the only lunate moves and everything stays in, it's a lunate dislocation. And in lunate dislocation, you will either have a pie sign where it looks like a pie, or it on a lateral view, it looks like a spilled teacup or pot sign. Whereas more common variety is lunate stays and everything else moves in, it's called as a perilunate dislocation. And in perilunate dislocation, which is more common type, or a lunate dislocation, it is the median nerve which is usually paralyzed. All right. 4 complications of trauma, remember by the mnemonic CCMMSSFF. Compartment syndrome tight cast is a compromise of microcirculation. It is more commonly seen in lower limbs, deep compartments as compared to upper limbs. Pain is out of proportion to injury, not relieved on anything. And the classical sign is stretch pain at the distalmost joint. All right. The pulses are normal. Pulselessness is the last sign, right? The treatment is fasciotomy. You release up to deep fascia, and the indication is the pressure more than 30 or paresthesia being mentioned in the question. If you do not treat compartment syndrome on time, it leads on to a complication called as Volkmann's ischemic contracture. And in Volkmann's ischemic contracture, right, there is involvement of the forearm deep compartment causing FDP more than FPL involvement. The order of involvement of the nerves is anterior trochleus, median, and ulnar. And remember, because there's a flexion deformity, you give a splint, turnbuckle splint, or release the medial muscles from the medial epicondyle called as a Max Page muscle sliding operation, right? So compartment syndrome cast, and if you don't relieve the cast, don't relieve the pressure, it leads on to the contracture of the muscles. If you have a child with an injury around the elbow and an osteopath did a massage, it will form bone around it. This is called as myositis ossificans. It is usually around elbow, one side, brachialis more than biceps. Initial treatment is cast for first 3 weeks. After that, ask the patient to mobilize himself, called as active movement. If you do it, that's passive. It's equal to massage. Don't touch it, right? And if it is beyond 1 year, you operate it. M for myositis, M for massage. And then if you have a Colles fracture, the fracture unites with a sympathetic overactivity occurs, causing red hot shiny skin or patchy osteopenia. There is a triad called the Langfors triad, the trauma, the sympathetic activity and the response as shown here, right? And it can be two types. One is after trauma, that is Colles, or type 2, the nerve injury, the median nerve, called as causalgia. Treatment is continuous exercises. Whether it's compartment syndrome or myositis or Sudex, the results are always going to be poor. Fat embolism we'll do when we do fracture shaft femur, but these are the things to take away. Compartment syndrome, relentless pain, stretch pain, microcirculation affected, CAS is the cause. Myositis, massage, right? You decrease the movements, only active exercises are permitted. Sudex, sympathetic activity, red or shiny skin. Femur fracture, 48 hours is fat embolism, breathlessness, decreased saturation, and petechiae. Compartment syndromes are usually in the fractures of tibia and the deep compartment involved. Myositis in the elbow, brachialis is involved. Sudex is around Colles, and fat embolism is femur fracture after 48 hours. These are some of the nerves and their involvement: anterior or inferior dislocation of shoulder, axillary nerve; cervical neck humerus, axillary nerve; shaft humerus, radial nerve; supracondylar, AMRU; medial condyle, ulnar; elbow dislocation, ulnar; Monteggia, posterior introitius; Volkmann's is anterior introitius nerve; lunate is median; hip is sciatic; knee is common nerve. Elbow dislocation, posterior ulnar nerve, most common involved, and this is the most common joint to dislocate in children according to questions that are asked. So when we're talking about the loss of curvature of spine, I spoke about some curvatures. Let's have a look at this. Cervical spine has a lordosis, thoracic has a kyphosis, and lumbar has a lordosis. All right, so this is what is written here. The lateral curvature of spine is called as a scoliosis. It can be without a cause, all right, or it can be postural. To differentiate the two, you ask the person to bend forward. If it disappears, it's postural. If it stays, it's fixed. Idiopathic, you don't know a cause. Then you have congenital, where you have some anomaly in the vertebra. And the rule is every vertebra has two eyes, that is pedicles, and one nose. What you will see some wedges. You will see some half segmentation. You will see a vertebra inside a vertebra, or you will see the vertebrae are fused together. All right. So you will see different kinds where you will see one side the eyes are not there, or one side single eye is there. So this is what eye means, pedicle. So this is what are congenital anomalies. So they can show you an X-ray and they can ask you what type of scoliosis there. If you see normal vertebrae with just scoliosis, idiopathic, and if you see deformed or disabled or congenital anomalies in the vertebra, that's called as congenital scoliosis. Remember one more thing, the first movement of the neck, right, atlanto-occipital is yes, right, flexion extension is second, atlanto-axial is a no. So we are made positive by human beings. The angle which is measured in scoliosis is Cobb's angle. One more sign for treatment is called a riser's sign that you should keep in mind. Remember, when there is a spine injury, if there's complete loss of movement and sensations, called as spinal shock, and bulbocavernosus is the first reflex to come back. At the terminal end of spine, if there's an injury, it's called as conus medullaris. It is a symmetric injury, can have bowel bladder involvement. The horse's tail or the nerve roots coming out, if they are involved on one side, it's cauda equina, and it can also have bowel bladder involvement. The fractures of the vertebra, the first is the Jefferson fracture involving the ring of atlas called as JART. The second is the cervical vertebra 2, that is called as hangman's vertebra. This is a slip of C2 over C3. So this is spondylo, means vertebra listhesis, right? When there is injury to the spinous process of the lower cervical spine, it's called as a Clay-Shawler's fracture. If you're going in a high-speed vehicle, there's a sudden halt, you will go back and then come forward. This is called as a whiplash injury, hyperextension followed by flexion. When the skull divides into anterior, posterior, it is called as a motorcyclist or hinge fracture. And in spinal cord injury, without obvious radiological abnormality, means X-rays are normal, MRI can show you sign, is Skyvora seen in pediatric population less than 8 years of age. The cervical spine sometimes needs to be immobilized. The Crutchfield tongs are applied on the skull, but immobilize the cervical spine, giving it a traction. Remember that for the hip stability, gluteus medius minimus is important, the hip joint is important, and the nerve supply, the superior gluteal nerve is important. If you stand on one limb, that side can support the unsupported side by working on that side. But if you stand on one limb and the opposite side drops, it means the Trendelenburg test is positive on this side. So if I stand on right and the left drops, it means the right side is weak. So this is the mnemonic: drop of the opposite side is positive. So normal hip abductors and gluteal nerve is required for it. Positive means drop on the opposite side, and when both are affected, so that works with the waddling gait. The duck does not have good gluteus medius, so it waddles on both the sides. When you look at a lying patient and you want to measure whether the head of femur or the neck of femur is destroyed, you measure something called as a Bryant's triangle, which measures about the supratrochanteric area. So Bryant's triangle measures the supratrochanteric, which is the head and neck femur measurements, shortening. Remember, for the hip flexion deformities, you have something called as the Thomas test, and for tendoachilles tear, you something called as the Thompson test. So length of the word can help you diagnose. You did a Babcock's triangle for tuberculosis of hip. Now let's have a look at the Ward's triangle that talks about the upper end femur. It talks about the area, right, different tubercules which are there. When I look at the upper end of femur, all right, the basic point is that the capsule inserts along the intertrochanteric line. All right, the capsule inserts along the intertrochanteric line. All right, and the neck of femur or the intertrochanteric area is also called as the intracapsular area or the extracapsular area. All right. So remember, they can give you an image, neck of femur, that is intracapsular fracture, or the trochanters are gone, intertrochanteric fracture. The exams have shown you images. Remember, neck of femur fractures are known for avascular necrosis more than non-union, just like our the scaphoid. The blood supply comes like this. So that's got damage. So avascular necrosis of the head occurs. All right, retrograde blood supply. Similarly, in scaphoid, it's distal to proximal. So proximal pole undergoes AVN. Here, the head is proximal, undergoes avascular necrosis. Whereas in scaphoid, remember, my friends, we told you this, that non-union is more common than avascular necrosis. Further to this, remember one thing, that when you have a clinical presentation, then the neck of femur will have less than 45-degree external rotation, whereas in intertrochanteric fracture, the foot goes completely down. Marked shortening, marked pain. So they have increased pain, increased shortening, increased external rotation. So they are also called as extracapsular. So everything extra occurs in them. So extra, everything extra. Whereas neck femur will have less shortening, less rotation, less pain, but will have more complications. When we come to treatment, right? When we come to treatment, it's based upon reducing the fracture. So what do you want to do? You want to align the trabeculae of the acetabulum with the head, with the neck. So Gardner's classification talks about that in Gardner stage 1, only there's an incomplete fracture with valgus. It can unite. In Gardner stage 2, there is partial displacement. All right. In Gardner stage 2, the trabecula aligned, but the fracture is complete. In Gardner stage 2, there is incomplete displacement. Stage 2 is undisplaced. Stage 3 is incomplete displacement, partial displacement. All three trabeculae of the acetabulum, of the head and the neck are malaligned, all three malaligned. And stage 4, complete displacement. So the head will align with the acetabulum, but the neck goes away. All right. So remember, stage 3 and 4, they have same prognosis. 1 and 2, they have same prognosis. Horizontal fractures will have compression. They will unite. The vertical fracture will have a shearing forces. They will go away from each other. Powell said less than 30 degrees is grade 1, 30 to 50 is grade 2, and more than equal to 50 is grade 3. So as the angle increases, the fracture, right, becomes more vertical, chances of union becomes less. So this is what you should remember. And similarly, as the fracture goes on more proximal, because the blood supply is like this, the prognosis is worse. So subcapital has worse prognosis than transcervical, than the intertrochanteric. This is the anatomical classification, all for neck of femur. So when you're treating neck of femur less than 65, you put screws, and if it is more than equal to 65, you do hemiarthroplasty. Whereas in intertrochanteric fractures, you usually put a nail or you can put a dynamic hip screw. Remember, apart from the neck of femur, in the entire femur you put nails. There are three questions that came in INICT May 2024. Everybody spoke about nail, upper end, middle, lower. So it's all nail, nail and nail. This is what you should remember. Coming to the fracture shaft of femur, I just spoke about the nails. So gallows traction was used where you used to hang the child by the roof for 6 weeks for shaft femur less than 2 years of age, but the treatment for less than 5 years is spica. All right, this the cast that goes on the spine, right? This is what is very, very important. So fracture shaft femur, 0 to 5 years spica. 5 to 10 years titanium electric nail system called as TENS. More than equal to 10, you do interlock nailing. What is interlock nailing? Nail in the femur, lock it with a screw so it doesn't rotate, right? Hip dislocation, remember, posterior is more common than anterior. Posterior will have shortening and farther, anterior will have faber and lengthening. Shatena palsy can occur in posterior dislocations, all right, and long-term complications are osteoarthritis. If you look at this image, if you have hip flexion deformity, what test do you do? Thomas. When you have flexion, adduction, interrotation plus shortening, it is posterior dislocation. When you have flexion, abduction, extension plus lengthening, it is anterior dislocation. And when you just have shortening plus externalization, you have fracture neck of femur. It all came from one page in multiple exams. So there is flexion, abduction, externalization. The head is below and it's down and out. So down and out is anterior dislocation. When you look at a high-speed vehicle and there's a sudden impact on the knee, if your hip dislocates, it's dashboard injury, posterior dislocation. And when it goes on tibia, there's a PCL avulsion. So these are dashboard injuries where the posterior dislocation is more common than the PCL avulsion. Remember that in posterior dislocation, there is farther plus shortening. It's up and in. So it's up and in. The head is at the level of the joint and the thigh is in. The blood supply of the upper end of femur, the femoral artery, it crosses the head and you feel the pulsations along the head. But if the head dislocates, you won't feel the pulsation. And when you don't feel the pulsation, it's called as vascular sign of Narath positive. So vascular sign of Narath is positive in posterior dislocation. And this is what is the clinical presentation. Flexion, adduction, rotation after trauma is farther seen in posterior dislocation. All right. Some important fracture that has been asked in the exam. Tibial pylon is a fracture of the lower nerve of tibia. Intra-articular comminuted fractures. Talus, right? Any injury into talus will cause osteoarthritis of subtalar joints more than ankle joints, then the avascular necrosis. Calcaneal fractures, important thing is Bowler's angle, which lowers with the fractures, or angle of Gizane, which gains. Cobb's angle speaks about scoliosis. Kite's angle talks about the man who created everything on CTEV. CTEV, that is a club foot. Club means the gall stick. And Bauman's angle talks about the cubitus varus in the supracondylar humerus. So Bowler's angle lowers and Gizane angle gains in angles of in fractures of calcaneum. Q angle is measured around the knee, the quadriceps pull. Increased Q angle talks about the patellar subluxation. And then you have to look at the ratio of the length of the patella to the ligamentum patellum. So if the ligamentum patellum, right, length is smaller, it means the patella is low, called as patella baja. If the ligamentum patella, the strength is more, it's called as a patella alta. So this is called as the Insall-Salvati ratio. When you treat fractures, the initial treatments revolve from conservative, now it's getting operative. So the slab is on one surface, cast is circumferential. So hanging cast or the U slab is for fractures of humerus. All right. The PTB, the patellar tendon bearing cast, is for tibia. The cylinder cast is for the fractures of patella. The hand shaking cast is for coleus, and glass holding is for scaphoid. The Dunlop and the Smith traction is for supracondylar humerus. The figure of 8 bandage, I believe this is going to come to you in the exam, is for fractures of clavicle, right? Remember, for mallet finger is one of the commonest asked question to you. Avulsion of extensor tendon from distal phalanx, and it's treated non-operatively. avulsion of extensor tendon from distal phalanx, treated non-operatively. Baller-Brown splint is for giving tractions to the femur or the tibia. Russell traction, which was initially described as skin traction, is for intertrochanteric fractures of the femur. Agnes Hunt traction is to correct the flexion deformities of the hip. Jefferson fracture, some name fractures, is for Jart, is for Atlas. Hangman is H2, C2 over C3 slip. Nightstick is when a stick comes on the ulna. Nightstick fracture is an isolated fracture of ulna. Choppers is a fracture of radial styloid. Colles is a posteriorly displaced fracture opposite to the direction of first metacarpal. When you have deviations of the spine or there is compressions of the spine, there can be splints given. Milwaukee brace is something that goes to the chin, given for scoliosis. Boston brace, again for scoliosis, goes till the breast. B for breast, B for Boston. Ash brace is to correct the kyphosis, may be associated with osteoporosis, bone weakness. And Taylor spinal brace goes till the shoulder. Again for immobilization of thoracic and lumbar area, and many a time for the fractures. Now, when you have the pelvis, you can have different types of injuries. Either you have an injury involving the same side or the opposite side of the pelvis. So when it's posteriorly one side of the pelvis, anteriorly the opposite side, it's called as a bucket handle injury. The pelvis rotates like this. Or when it's both the sides and same side, anterior and posteriorly, is called as a Melgagny injury. Or when the posterior structures, forces onto the anterior structures to open up, called as an open book injury. Or just the anterior injury, the straddle fracture. When you're sitting on the horse, you're riding, this is the superior inferior pubic rami getting damaged with the straddle. All right. This is what is around the ankle, the pylon fracture, the lower end tibia intra-articular fracture. The talar fractures with a vertical height fall is called as the aviator's fracture. Or when there is avulsion of the tip of the fifth metatarsal base, that's pseudo-Jones, and when it's a little proximal, it's called as a Jones fracture, the metaphyseal-diaphyseal junction. Jones is also called as a dancer's fracture, right? Then the upper and humerus proximal fractures, they are classified by Need's classification, dividing into the head, the greater tuberosity, lesser tuberosity, and the shaft. More the parts, the more the complication. Supracondylar fracture humerus goes posteriorly. Galeazzi is a fracture of radius with damage to the distal radial ulnar joint. Monteggia is a fracture of ulna with damage to the dislocation to the radial head. Boxers is a fracture of fifth metacarpal neck. Bumpers is a fracture of the lateral tibial plateau. Cottons is a fracture of medial malleus of tibia. Lateral malleus of fibula, that is the fibula lateral malleus, or the posterior part of the tibia called as posterior malleus. So it is CT. Cottons is a trimallar fracture, whereas Spots is a bimallar fracture, means fracture of the medial malleus and the lateral malleus. Chopard's is related to intertarsal area, remembered by the mnemonic SIT. Chopard's is intertarsal, whereas Lisfranc's is very simple, tarso-metatarsal injury. These are anatomical terms. Chopard's and Lisfranc are anatomical terms, and March is a fracture of the neck of the second or third metatarsal in this order, which is a type of a stress fracture. Runners again is a stress fracture of the lower end of fibula. And then I told you, Nee's classification is for upper and humerus. And one more classification you should remember, Dennis is a 3-column theory classification, where anterior part of the vertebral body with the anterior longitudinal ligament is the anterior column. The posterior part of the vertebral body with the ligament is posterior column, and rest everything is posterior. So if 2 out of 3 of the parts, the columns are involved, it's an unstable injury, and posterior is the most important one. When you treat a fracture, you can apply tractions to it, either to the skin, where you can give 4 to 5 kgs of weight, or you can put a pin inside the bone. Either it can be a simple Steinman pin, or it can be a threaded Denham's pin along with a bowler stirrup. Denham's pin is for osteoporotic injuries, osteoporotic bones, and Steinman is for a normal bone. So you put traction to it, and what is the upper limit of putting skeletal traction? 10% of the body weight, but one book describes up to 20 kgs in posterior dislocations. So upper limit is for the skeletal is 20 kgs and the skin is 4 to 5 kgs. When it's an open injury, open fractures, it's classified by Gustlow-Anderson classification. External fixators are applied. Remember, when it is a fracture of patella or olecranon or medial malleus, you want to apply tension band wiring. What does the tension band wiring means? It means the convex surface of the bone has a muscle pull. You fix that up. So the conversion of distraction forces into compression forces is called as a tension band wiring. Close the tension surface. It's a principle. You can apply a wire or a plate, but classical is fractures of patella, tension band wiring is done. When you were treating by primary healing, we were applying a plate to compress the fracture sites with no callus formation. The initial plates, they were plates and the screws, they were holding the plate, but they realized they were degloving the bone. So they made grooves in the bone. So the initial plates were called as a dynamic compression plate, but then they created grooves in the bone called as limited contact dynamic compression plates, which allowed some vascularity to prevent. But the problem was the screws were coming out, whether it's a cancellous screw in the cancellous bone with some spaced out threads or a cortical screw with closer threads, they were coming out. So they thought, why not to put screws with threads in the head, which will lock with the bones having with the plates having threads. These were called as a locking screw and these won't come out. So nowadays the locking screw and plates are used very commonly for metaphyseal injuries, for the weaker bones, for the cases of non-union, or when there's already very less space, like prosthesis, they are periprosthetic fractures. Nowadays, locking plates are very, very commonly used in literature. Some instruments that you should know: osteotome, curette, bone cutter, the king of all, bone nibbler, bone plate holding, because it has tooth, so bone plate holding, bone holding all around. Whatever has tooth, so they are bone holding fossa. These are some of the instruments you should know. When you have the long bones, right, like the lower limb, you need to put a nail and lock them with the screws, called as interlocking nails. I told you, upper limb are usually plated, lower limb bones are usually nailed. You can have interchangeable things, but this is the usual dictum. Small children usually cast, sometimes K-wires, that is stainless steel wires. Open injuries, external fixators. Now, external fixators, more the planes, more stable it is. If you apply in one plane, uniplanar, less stable than biplanar, which is less stable than the Ilizarov, which is all around. All right. So Ilizarov is used to lengthen the limb. If there's a shortening present, it can be used for lengthening. And one more fixator which is used for lengthening is a rail fixator nowadays. Remember that this question came in the NEET last year, that a patient has a chronic history of pain, and this is the image. What do you think it is? So this is a bipartite patella. All right. And what do? You usually don't do anything in this, just train conservatively, get the x-ray of the other knee. Arthritis, the rule is OA, RA. When you point the finger towards somebody, the two joints that look towards him are involved in OA, osteoarthritis, DIP, PIP. And when you call somebody towards you, RA, rheumatoid arthritis. OA involves the base of first metacarpal, that is carpometacarpal joint. RA involves the wrist joint. Remember this. So, in osteoarthritis, you have DIP involvement, knee medial compartment involvement, hand first carpometacarpal involvement, genu varum at the knee. When you have osteoarthritis knee, quadriceps is the most commonly wasted muscle. And when a person, because of osteoarthritis knee, cannot walk, you need to operate. Less than 60, there is varum, seedha kar do. Cut the bone, make it straight. Cubitus varus, if deforming, causing any problem to the patient, cosmetic correction. Cubitus valgus, if causing tardial nerve palsy and not resolving, cosmetic plus functional correction. But here, the activities are not being able to perform. This is a therapeutic correction. So here you cut the bone. Most of the deformities in human body are varus, so they have to be cut. Take out a wedge on the lateral side, straighten out. High, upper end, tibia, tibial, osteotomy. And if the patient is 60 or more, total knee replacement. Rheumatoid arthritis, RA. So these two joints are involved. DIP is paired. MCP is the commonest involved. Knee, valgus. Remember, in hand deformities are very common in RA, the swan neck deformity, where the DIP flexes and the PIP hyperextends. The opposite of is bout neck deformity, ulnar deviation of fingers. Young man, low backache, sacroiliitis, decreased movement, decreased lumbar movement, whole skeleton white, HLA B27 positive, ankylosing spondylitis. Grade 2 inflammation, gout, uric acid crystals, negatively birefringent means if the light is shown on them, it deviates to the left side, called as polarizing microscopy. So negatively birefringent, and then they are needle shaped. Remember, painless joints seen in diabetic because of loss of proprioceptive fibers in the midfoot are called as Charcot joint. Only two conditions are painless, mycetoma and Charcot's. All right. Going to the hand, if they are showing you DIP involvement with nodes, Hubbardon nodes, this is an osteoarthritic hand. PIP swelling, Bouchard node, osteoarthritic hand. Remember, in OA, they will show you the front view. In RA, usually this the side view. In RA, the side view, only the front view when the ulnar deviation of finger is shown. Otherwise, OA, the front view. In osteoarthritis, there is reduced joint space, sclerosis beneath the joint called as subchondral sclerosis, or increased bone formation around the edge. Knee goes into varus called as genu varum. Medial compartment involvement and quadriceps is wasted. In osteoarthritis of the knee, remember the O is between the legs. In rheumatoid, there is an R there, right? In osteoarthritis, if the patient is less than 60 and the deformity is to be corrected, take out a wedge of a bone and straighten it, called as high tibial osteotomy. More than equal to 60, do a total knee replacement. In osteoarthritis, the cartilage gets destroyed. In rheumatoid arthritis, it is a synovial proliferation calling periarticular osteopenia. Remember, in osteoarthritis, it is the genu varum causing quadriceps wasting. When you look at the hands, the penicillin cup deformities, right? The penicillin cup deformities are characteristically seen in psoriasis. So, psoriasis. Because the DIP involvement is very common in psoriasis. Whereas acroosteolysis can occur in a lot of bone destructions, but scleroderma is one of the common names that should come to your mind. Remember that there can be totally destroyed hands in RA called as arthritis mutilans. You can have ulnar deviation of fingers. I told you the AP view is very rare to be seen. Or what you have flexed DIP, hyperextended PIP called as swan neck deformity seen in RA, or opposite of it, hyperextended DIP or flexed PIP seen in Pautonnier deformity of RA. You can have deformities of the thumb in RA. So RA hand is very commonly shown to you. Remember, in ankylosing spondylitis, HLA B27 positive, sacroiliitis, young man, enthesitis means insertion of ligaments and tendons are inflamed, like heel pain. Sacroiliitis is one of the same things. Or they will have red eyes, reduced chest expansion, decreased lumbar movements, right? So sacroiliitis, the skeleton is all white, called as a bamboo spine. So this is a bamboo spine. You can have the calcification along the facet joints, the interspinous ligaments, right, called as a trolley track sign, or the supraspinous, it is an infraspinous calcification called as a dagger sign. This is a classical thing in ankylosing spondylitis. Now, when you look at ankylosing spondylitis versus skeletal hyperostosis, which is more of a disease, more of a radiology in the clinical presentation, it is called as DISH, or diffuse interstitial skeletal hyperostosis. All right, also called as the Forestier's disease. All right, so you will see flowing calcification in them, or you can have ochronosis or alkaptonuria causing the intervertebral disc calcification coming to you. Remember one thing, inflamed great toe with uric acid crystals which are negatively birefringent in a middle-aged man with history of protein and alcohol intake is gout. So you will have grade 2 inflammation gout. There can be overhanging bony edges called as a Martel sign, which is seen, and there can be rat bite erosion seen in gout. Whereas in pseudo gout, it is calcium pyrophosphate crystals. They are rhomboid shaped and they will cause chondrocalcinosis, that is calcification of the menisci and cartilage. Here, the crystals are rhomboid and positive birefringent, means throwing the light on the right side. Charcot's in diabetes involving the midfoot joints, right, is a neuropathic joint due to loss of proprioceptive fibers. Now, this is chondrocalcinosis, pseudo-gout. In hemophilia, there is usually a lot of changes in the bone. They are enlarged epiphyses, right? The squaring of patella, widened intercondylar notch, and all around the joints osteopenia. This widened notch is classical of hemophilia, can also be seen in tuberculosis and rheumatoid arthritis, juvenile rheumatoid arthritis. Most common cause of a loose body in a joint is osteoarthritis. Most common cause of multiple loose bodies is synovial chondromatosis. You can see lots and lots of loose bodies. All right. Remember, neck shaft angle is normally, neck to shaft angle of femur is normally 135. When the angle is less than 120 degrees, it's called as coxa vara. When it is congenital, it's called as congenital coxa vara. And you will see a triangular piece of bone just at the angle here in congenital coxa vara, called as Fairbanks triangle. Ward's triangle tells about the bone density, normal bone. Babcock's tuberculosis is very common, right? Fairbanks triangle, congenital coxa vara. When the angle is more than 140 degree, valgus, coxa valga. When we talk about metabolic disorders of the bone, remember, when there is widening, it's rickets. When the skeleton is whitened out, it's scurvy. Rickets is vitamin D deficiency. The calcium is normal to low. The phosphate is low. Phosphate is only high in renal rickets, because in renal rickets, they lose calcium and they retain phosphate. So hyperphosphatemia occurs. All right. Alkaline phosphate is because rickets is a mineralization disorder. Osteoblastic activity increase, so alkaline phosphate is high. And because the same reason, because there is less calcium, all right, the parathyroid hormone is activated, PTH levels are high. In rickets, you will have the ping pong skull, which is the earliest feature of a rickets. Otherwise, the clinical finding is usually broadening around the joints. All right. When I look at some of the points you should remember here, rickets is widening, scurvy is whitening. The Wimberger ring sign of scurvy is at the epiphysis. This is a classical sign of scurvy, whereas white line of Frankel is at the metaphysis. You will just see that. In hyperparathyroidism, you will have bone resorption everywhere. When this causes a lytic activity, it's called as osteitis, means bone fibrosa cystica. And when in these cysts, the blood comes, it becomes brown tumor. The classical hyperparathyroidism features are, right, psychic moans, means irritable behavior, abdominal groans, means dyspepsia, renal stones because of hypercalciuria, or bone pains. Here, when the blood degradation products in the cyst becomes gives it a brown color, it's called the brown tumor. And on the skull, there are dots. We saw that salt pepper skull. Paget's and osteoclast defect will usually have pain to the patient, and it's usually seen in the pelvis. The whole vertebra is white, called as ivory vertebra, or the borders are white, called as picture frame vertebra. The skull size keeps on increasing, called as, right, cotton wool skull. In osteopetrosis, another osteoclast defect, you will have dense and lucent lines on the vertebra, called as rugger jersey spine. And here the whole skeleton appears white with no marrow, called as marble bone disease. The decreased bone density is called as osteoporosis. Here, the quantity is less, the quality is okay. So, calcium, phosphate, ALP are normal. You measure screening after 65 years in females and 70 in males. Remember, DEXA, dual emission X-ray absorptiometry scan is done for it. And the T-score, we go in negative, less than minus 2.5, indicates osteoporosis. Right, the order of involvement is vertebra, hip, and choles. These are the areas where the fractures can occur, and the vertebral fractures or vertebral compression leads on to the codfish shape, called as codfish vertebra, which is the intervertebral disc rather than the vertebra. And remember, codfish vertebra are more common in osteoporosis than osteomalacia. The drug of choice is bisphosphonates for osteoporosis. This is something that you should keep in mind. Osteogenesis imperfecta is a type 1 collagen defect and leads on to multiple fractures since childhood. So now let's have a look at the rickets. So rickets will have cupping, splaying. Cupping means shape, splaying means width, flaring means the edges goes out. When you give calcium and vitamin D, the white line of Frankel comes. It's called as healing rickets. It's in the metaphyseal dense line. Again, rickets, widening. And remember, epiphysis is always normal in rickets. The adult counterpart of rickets is osteomalacia, can have coxa vara, can have multiple fractures of insufficiency called as pseudo fractures, and can have triradiate pelvis. This is osteomalacia, more common in females. Remember, the diagnostic tool for osteomalacia is a biopsy, where you measure the ratio of the mature and immature bone. Osteon is a mature mineralized bone, osteoid is immature bone. The mineralization defect of rickets occurs in child, osteomalacia in adults. Rickets can have genu varum, can have genu valgum, can have rachitic rosary, or just a sulcus beneath the ribcage called as Harrison's groove. All right. Scurvy is whitening. When the epiphysis has a Wimberger ring sign called as whitening around the epiphysis, or there can be a white line of Frankel seen in the metaphysis. So this is scurvy. So in rickets, white line of Frankel will be there, but not Wimberger ring sign. Scurvy, white line of Frankel will always be there, and Wimberger ring sign will always be there. So if you look at this, this is all white. That's scurvy. Rickets is wide. So there is widening in rickets and whitening in scurvy, right? Hyperparathyroidism will have lytic cavities if they are filled with blood, brown tumor, will have salt pepper skull, will have osteopenia all around. The lining of the tooth socket, the lamina dura, will be lost, and because there will be secondary calcifications occurring, there will be rotting fence post appearance, which is like we used to draw those fence posts as a child when we used to draw our images. So there appears to be the bone with rotting fence post appearance. This is hyperparathyroidism. Psychic moans, renal stones, abdominal groans, and bones. Usually a young female is the feature. When you have ossification defect, there are two types. One is an end-condyle ossification defect, where the trunk size is normal, but the limb size is short, right? This is called as achondroplasia. Here the pelvis appears to be widened, called as a champagne glass pelvis. You have the trident-shaped fingers, that's the trident hand, or you have all the fingers equal, called a starfish hand, and you have the bullet-shaped vertebrae. These are the features seen in end-condyle ossification defect, whereas when you have intramembranous defect, which is in the mesenchymal defect occurring because the ossification of the skull bones or the clavicle, the only long bone which ossifies by the intramembranous ossification, your clavicles are absent and your shoulders can meet in the midline, right? This is called as a cleidocranial dysostosis. Cleido means clavicle, cranium means the skull. So they have squashed face, that's what is there. Osteoclast defects are two, osteopetrosis and Paget's. In osteopetrosis, you have absent bone marrow, so you will have pancytopenia, anemia. Because anemia, so hepatosplenomegaly, the nerve roots are compressed, the second, seventh, and eighth. You will have marble bone appearance, but the shape is normal. The bones will have horizontal stripes called the Rugger-Jersey spine. It can classically seen in CRF, or you can have bone within a bone appearance, which can also be seen in sickle cell anemia. In osteopetrosis, you can have lower end of femur looking like a flask, which is classically seen in Gauchers, but can be seen in osteopetrosis as well. Paget's, which has multifactorial cause, is again an osteoclast defect. It is also called as osteitis deformans, where more osteoblastic activity is there, causing increased alkaline phosphatase. More osteolytic activity is there, causing increase in the hydroxyproline, which is a marker for bone resorption. And there will be different phases in which there will be pain. Pelvis is the commonest bone affected. They can be marking around the bone of the vertebra, which is thickened, called as picture frame vertebra. The entire vertebra can be white, called as the ivory vertebra, right? Or the skull can have more deposits, causing increasing head size, which I told you is classical in acromegaly, can also be seen here. Or there can be a large osteoporosis, or the shape can change, like a tam o' shanter hat. which is classically seen in Paget's. There can be resorption of the long cortices of the bone called as blade of grass appearance, or there can be thickening of the pelvic brim called as a brim sign. These are all features of Paget's. Here also, all the feature of Paget's. All right. Then osteogenesis imperfecta, there is collagen 1 defect, complete crumpling of the skeleton, whereas osteopetrosis will have all the skeleton white, the shape being maintained. When I look at different vertebrae, the Rugger Jersey spine is CRF, chronic failure, more than osteopetrosis. The bamboo spine is ankylosing spondylitis. The codfish vertebra is osteoporosis more than osteomalacia. The bullet-shaped vertebra is achondroplasia, and the ivory vertebra and the cotton, and then the picture frame vertebra is Paget's. And remember the blue sclera. What do you think is there in blue sclera? Which disease? Good. Osteogenesis imperfecta, the collagen 1 defect. All right. If somebody comes to you and says whether my limb will survive or not, I had a crushing injury, you will calculate the MES score, mangled extremity severity score, and you will have 4 things in it: shock, ischemia, velocity of trauma, age of the patient. If the score is more than equal to 7, it goes for amputation. If somebody comes to you and says, please, this thumb got away, can you put it fixed? That's called as reimplantation. In reimplantation, the first structure to be fixed is bone, then the extensor tendon, then the flexor tendon, then artery, nerve, vein, and the last is the skin, because if you don't cover the white structures with the skin, they will die. If you have an amputated part and it's a lower limb, and you want to put a natural looking foot in India, you will put Jaipur foot made by Dr. P.K. Sethi, which allows you to squat, walk on uneven grounds, and which allows you to walk barefoot. Whereas the Sach foot, that is solid ankle cushion heel, is an artificial looking foot of a Western lifestyle, which does not give you these advantages. Remember that in our knee, there are different areas, like the anterior part has a ACL, which limits hyperextension rotation, but posterior part has a PCL, which limits external rotation. The test for that is called the dial test for the posterolateral corner. You flex and rotate. All right. The most common ligament damage in human body is anterior talofibular ligament. Most common tendon damage in the human body is supraspinatus, then the biceps, right? And then the tendoachilles. And the biceps tear is also called the Popeye if the long head of biceps is gone here. Remember, hallux valgus is the lateral deviation of great toe. When I look at the inflammations around different body part, tennis elbow is lateral epicondylitis, golfers is medial, student's elbow is olecranon bursitis, housemaid's knee very commonly as prepatellar bursitis, and clergyman's knee is infrapatellar bursitis. When in diabetic patient, there is fusion of the capsule, it's called as frozen shoulder, also called as adhesive capsulitis, and treatment is plan A. So I've told you 2 conditions very common in diabetic: Charcot's and frozen shoulder. Plan A is rest plus NSAIDs, if not relieved, local steroids, if not surgery. All these conditions are also treated by plan A. Painful arc syndrome means first 60-degree abduction, no pain. 60 to 120 is painful, beyond 120, no pain. This is painful arc syndrome. Mid arc is painful, treatment is again plan A. All right. So what you need to understand is these are some of the common questions asked. Mallet finger, I've already told you, is one of the commonest line asked in entrance exam. Avulsion of extensor tendon from distal phalanx. Treatment is splint for 6 weeks. Opposite of it, avulsion of flexor tendon is a jersey finger where you operate. When I look at the knee joint, in the knee joint, if I go into varus, if I take my knee into varus, right, varus, the lateral collateral ligament is tested. So varus test is for lateral collateral ligament. When I take the knee into valgus, the medial collateral ligament is tested. When I flex the knee into 90 degrees and I try to do hyperextension, it means ACL is gone, anterior broad test. When I do it in 20 degrees of flexion and I try to pull tibia anterior, it means again hyperextension, ACL is gone. When I try to pull out the anterolateral aspect of tibia, it means I'm again looking for a pivot shift test, ACL is gone. So these are the tests for ACL. Anterior drawer, Latchman, pivot shift, and out of them, the Latchman is the most important one because it has ACL. All right. When I look at the posterior cruciate ligament test, I am trying to do an external rotation, that is the dial test. We had shown that this is a very commonly asked question. And when I'm testing the menisci, medial more than lateral, and I hear the click, that's called as a Muck-Murray's test. So PCL restricts external rotation, we have done that. The most posterior structure on the tibia. ACL, the hyperextended rotation going anteriorly from the femur to the tibia. MAM is dangerous. It's a triad around the knee joint, which includes the medial collateral ligament, the anterior cruciate ligament, and the medial meniscus. These three, when gone together, is called as the O-Nonox triad. The blood supply of the meniscus comes from out to in. So the peripheral 1/3 is vascular, can be repaired. The inner 2/3 is usually excised. The medial meniscus is fixed to the capsule, so it is damaged more commonly than the lateral meniscus, right? So this is, you should remember, anterior to posterior, the structures on the upper end of tibia. Medical College, Lucknow Medical College. So anterior horn of medial meniscus is the first one, followed by the anterior cruciate ligament, then the anterior horn of lateral meniscus, then the posterior horn of lateral meniscus, right? Then the posterior horn of medial meniscus, and the most posterior is the posterior cruciate ligament. So this is what this Medical College, Lucknow Medical College. When I look at the hand, the different tendon zones, right? The zone 5 is of the forearm, right? Zone 4 is carpal tunnel. Zone 3 is lumbrical. Zone 2 is the crossover tendons, that is the FDS. And zone 1 is FDP. Remember, right? The jersey finger is zone 1. So zone 2 is no man's land. If you operate there, the results are poor. The movements will not come. Disc prolapse is the movement of the disc, the nucleus pulposus compressing on the nerve root. Remember, the lower nerve root is most commonly compressed. L4, L5 is the commonest disc prolapse. So the L5 is the commonest nerve root which is compressed. MRI is the investigation of choice. Treatment is plan A, that is rest plus NSAIDs, if not release local steroids, if not surgery. Now, you should remember that the important nerve roots for upper limb and lower limb. The upper limb, the C5 does the elbow, shoulder abduction, elbow flexion. C6 does the wrist extension. C7 the elbow extension. C8 the finger flexion. T1 intrinsic muscles of hand. So these are the important nerve roots, right? Coming to the sensory supply, remember, right? In hand, C5 and T1 do not supply. C6 is thumb. C7 is index finger and the middle finger, and C8 is ring and little finger. C6, C7, C8, right? Many of you will not be able to do this. Don't worry, it's a normal thing, okay? C6, C7, and C8. This is trident hand, a way to remember. Whereas in lower limb, L2 is hip flexion, L3 is knee extension, L4 is tendoachilles, that is ankle dorsiflexion, and supplies the middle part of the foot. L5 is extensor hallucis longus, great toe going into extension, or supplies the dorsum of the foot, including the great toe all around. S1 is flexor hallucis longus, great toe going down, and sole with little toe all around. All right, so this is important to find out which nerve is impressed. So L5 is the most commonly involved nerve root in the disc prolapse. All right, what is spondylolysis? Is slipping of one vertebra over the other. What is spondylolysis? Break in the interarticularis. We will just see that. When there is break in the pars interarticular vertebra, it is called as a dog with the collar in the neck. And when, because of this break, the vertebra slips, it is spondylolisthesis. So, dekho, spondylolysis more commonly occurs in L5, and listhesis occurs because of it into L5 S1 vertebra. So, this is a vertebra, a dog. The ear of the dog is superior articular process, the front leg is the inferior articular process, and the neck is the pars interarticularis. Whenever I jump, I turn, I twist, I break this area. So, when it breaks, it is called as a dog with a collar in the neck, spondylolysis, which occurs at L5 vertebra. All right, and when it separates out, it is called as beheaded dog. Beheaded Scottish Terrier sign occurs between L5 S1, and this is a disc prolapse. All right, so this is disc prolapse, which most commonly occurs in L4-5. Here it is L5 S1 shown, but most commonly L4-5. Spondylolysis L5, listhesis L5 S1. All right, this is what you should remember. Now, when I look at if somebody tries to catch a ball and the thumb goes into hyperabduction, the ulnar collateral ligament of first MCP is damaged. This is called as gamekeeper's thumb. If a muscle gets entrapped here, the muscle is adductor pollicis. It is called as a Stenner's lesion. It will not allow it to heal, otherwise it heals with a cast. All right. Similarly, if I am doing overuse of my elbow and the extensor carpetalis brevis and more than longus, they are inflamed, it is tennis elbow. The dorsiflexion of the wrist is painful, called as the Cozain test. Golfer's elbow is medial epicondylite. Student's elbow is olecranon bursitis. Housemaid's knee is prepatellar bursitis, remembered by this PH. Clergyman's is infrapatellar bursitis. Weaver's bottom is ischial tuberosity. Tailor's ankle is lateral malleolar bursitis. Bunion is around the great toe. Bunionate is around the fifth metatarsal base. All the treatment is plan A. There is one more inflammation around the thumb, the first extensor compartment called as abductor pollicis longus and extensor pollicis brevis. If you flex the thumb inside, make a wrist and take it towards the ulna, this is called as a Finkelstein test. If it's positive, this is called as decurvent stenosynovitis. Treatment is plan A. All right. Now, in diabetic, the third condition, the first one was the Charcot's, the second one was frozen shoulder, and the third one is the Dupuytren's contracture, where there is a contracture of the palmar aponeurosis, which involves the ring and the little finger, and there is a flexion deformity occurring. So, more than 30-degree deformity of MCP or 15 degrees of interphalangeal joints requires a surgery. It is seen in diabetics, it is seen in alcoholic, HIV positive, tubercular, epileptic patients. All right. And remember, how do you differentiate claw hand? Claw hand will have hyperextension at MCP, but ulnar claw hand will involve ring and little finger. Same as with Dupuytren's, ring and little finger, but it is a flexion. So, the lateral view will help you understand that. Coming to fingers further, mallet finger avulsion of extensor tendon treated non-operatively, jersey finger avulsion of FDP zone 1 operative treatment. Remember, hallux valgus is lateral deviation of great toe, all right, and Haglund deformity is a prominent calcaneal tuberosity, right, seen around the ankle. Coming to osteochondritis means damage to the cartilage of the underlying bone. It is a vascular phenomena usually occurring before the skeletal maturity. This is called as a Kienbock disease, which involves the lunate, Kohlers, which involves the navicular, Panners around the capitulum, the first bone to ossify around the elbow, the Perthes between 4 to 8 years, avascular necrosis of femoral epiphysis, Sherman's disease, the ring of the vertebra, calves, the central part of the vertebra, Freiberg's second metatarsal head, Iselin fifth metatarsal base, Osgood-Schattler's the tibial tuberosity, Johnson-Larson's the lower pole of patella, osteochondritis dissecans almost everywhere, most commonly the knee joint, and Sievert's is calcaneum, right? So, this is very, very important. A, vascular necrosis. Death of a bone due to poor blood supply can occur most commonly at the head of femur, can occur at the proximal pole of scaphoid or lunate, can occur at the capitulum, can occur at the distal femoral condyles, can occur at the head of humerus. They usually occur at the areas where the blood supply is retrograde. So, why? Because if it comes like here, the damage will cause AVN of the head. In the scaphoid, damage will cause the proximal pole AVN. Avascular necrosis. Avascular necrosis. In the head of the humerus, it causes whitening, snow cap sign. Wherever there is AVN, it will appear more white. In the femur, it causes anterolateral aspect of the femoral head. A crescentric lucency is seen called as crescent sign. MRI will show you a double line sign, which is the diagnostic investigation. In avascular necrosis of the head of femur, you can decompress the pressure called as core decompression, or you can put a muscle pedicle graft with blood supply. But today's world, it usually runs on replacement. Total replacement happens to be the most common surgery performed as the same. Coming to this, what is the diagnosis? Popeye. What has happened here? The long head of bicep, the shoulder is gone. This is what is very, very important for you. When we look at the pediatric orthopedics area, at birth, because of shallow acetabulum, we have a condition called as developmental dysplasia of hip. Its investigation of choice is MRI, screening tool is ultrasound, and on ultrasonography, the alpha angle decreases. This is what you should remember. The treatment of any hip disorder is basically what? Maintain the hip abduction. If you maintain the hip abduction, the hip gets reduced normally. So, reduction on abduction is the key word here. Also remember one thing, that DDH is a condition which is congenital. But if the hip condition comes from 4 to 8 years, painless limp in a child, that's called as Perthes. It's an avascular necrosis of femoral epiphysis. And when between 11 to 20, because of hormonal disorder in obese, overweight child, the epiphysis and the metaphysis relationship is disturbed, is called as slipped capital femoral epiphysis. This has to be reduced and fixed. So basically, in all these conditions, with time it can resolve. The most common congenital anomaly in India is CTEV, called as club foot because it resembles the club, which is scored by Pirani sign. Remember two things: ball and socket joints, when they are damaged, two movements which are lost are abduction and internal rotation. If at the hip and shoulder abduction and rotation is normal, it means they are normal. So here the examiner is trying to show internal rotation because the leg goes out but the hip goes in. This is very, very important. External rotation is not very important. Although the leg goes in, the thigh comes out. DDH, right? There is shallow acetabulum, small epiphysis, Shenton's arch. Shenton's arch is broken. Vascular sign of Narak positive. Suprolateral is the displacement. In DDH, if you try to do the signs, there are two signs. Ortolani means reducing the hip, means reduction by abduction. O, reduction by abduction. Ortolani is a test of reduction by abduction. Ortolani, hip ko andar lana, right? Bahar lo, dislocation on adduction, bar lo. So these are the two tests for that. All right. Now, what you need to remember is in DDH, you can give a Pavlik harness, all right, or a Von Rosen splint. Von Rosen views is for DDH, Von Rosen splint is for DDH, or you can give a bachelor's cast. They all are on the same principle, abduct the hip. Whereas you have avascular necrosis of femoral epiphysis, age group of 4 to 8 years, all right. You can have lytic cavity in the epiphysis or metaphysis, or you can have at the upper end of femur a sagging rope sign, or you can have a crescentric sign. It all means there's a vascular insult. Treatment, maintain abduction. 4 to 8 years, painless limb. Investigation of size DDH, MRI, Perthes, MRI. Then comes if your sternocleidomastoid, sternum, cleidoclavicle, mastoid, this muscle, all right, undergoes shortening, you have a torticollis or a wry neck. It is not necessary to be present in the first 3 months of life. Majority of the cases, 90%, they disappear by 1 year. All right. The ear is towards the shoulder, the chin opposite. All right. Along the cervical spine, normally the segmentation occurs. If the segmentation of the cervical vertebra does not occur, it is called as Klippel-Feil syndrome, which has low posterior hairline, restricted neck movements, and short webbed neck. It is associated with short high scapula called as sprangial shoulder. Pseudohypertrophy of calf is a feature of Duchenne's muscular dystrophy. Duchenne's, right? Muscle dystrophy is a dystrophin gene mutation, which is the largest gene in human body, which has a proximal muscle weakness. The patient has difficulty in getting up from the ground. He uses the support of his own body called as a Gowers sign. All right. Rocker bottom foot means that there is vertical talus. Normally the talus is horizontal. So there is a vertical talus and it looks like the toy. So that is rocker bottom foot. Rocker bottom foot will occur if you do not treat CTV in the correct order. What is the correct order of treating CTV? CTV is a component of 4 deformities, which are remembered by the mnemonic cave. So what is there? There is equinus and ankle, varus or medial rotation of the subtalar joint, adduction or a medial rotation of the midfoot and forefoot, and increased plantar arch called as cavus. So first to treat is cavus, that is plantar arch, then the adduction, then the varus, then the equinus. If you don't treat it this way, the CTV or the club foot, you will lead on to rocker bottom foot. This is a club, which means the CTV. This is a golf ball on a tee. That's how a shoulder relationship is. A large ball, this thing. So this photo describes two things, a club foot and a shoulder joint, just to explain you that, right? So in CTEV, you have a large lateral border and you have a small medial border and tight medial structures. The aim is to equalize both the borders, all right? So how do you do that? At birth, you apply manipulation and cast. You do it up to 1 year. The cast is supposed to be above the knee and you change it every week. This is the method of treating CTV, which is very, very important. This is the Ponseti method. If it doesn't correct by this way, right, between 1 to 3 years, you will release the soft tissues on the medial side called as a turquoise method. Beyond 3 years, Since you have a varus foot, you will take out a wedge of a bone, more on the lateral side, less on the medial side, right? This is called as soft tissue release plus lateral column shortening. So soft tissues are tight, you will release them. At different ages, you do different procedures. Like between 3 to 8 years, you will do Evans. So you will do a wedge resection like this. Beyond 5 years, right, you have to correct the heel independently. So again, the same thing, more on the lateral side, less on the medial side. All the varus deformities are corrected the same. If you go beyond 8 years, then you take out a multiple tarsal bones wedge. Or if it is beyond 10 years, more than equal to 10 years, you will fuse the joints, that is talonavicular, talocalcaneal, calcaneocuboid. So calcaneocuboid, talocalcaneal, talonavicular. And talonavicular is the most difficult to fuse in CTEV. Once you have corrected CTEV, at the daytime, a child will wear CTEV shoe with a straight medial border, with outer shoe race, with no heel. And at the night time, it will apply a Dennis Brown splint so that the correction is maintained. Till what age? Till the age of 7. All right. In a childhood injury, you can have 3 types of injury in a bone: a deformation with no fracture, just the buckling of the cortex, like the buckle at the base of a Roman pillar called as a torus, or fracture of one of the cortices with a bending of the other called as a green stick fracture, right? There are certain deformities that one should be aware of. Anterolateral bowing of the tibia is congenital pseudoarthrosis of tibia. It's an intraoperative diagnosis treated with stabilization and grafting. There can be absent axis of one of the limbs. That absent axis of one of the limbs means the radial hemimelia, means the radial side is absent, thumb is absent, the artery is absent, the vessels are absent. This is called as a radial club hand, all right? Or the fibula can be absent with short feet, less number of toes, or the tibia can be absent with tibial hemimelia, or there can be a self-resolving condition called as posteromedial bowing. So these are the conditions which you should know. Hemimelia means that half axis is absent. Now, when you have less development of one part of the radius, right, it is called as made lung deformity. So made lung deformity causes prominence of the lower part of ulna. It is seen in Turner syndrome. 50% cases are bilateral, more common in females. Functionally, it's almost normal. And my friends, a spot diagnosis fusion of two fingers or digits is called as a syndactyly. So this is all about the quick revision in English that I wanted you to know. And to further enhance, I will suggest you can go to the English version also, so that you are able to brush up your knowledge in a quicker way in a different language. Thank you very much.